cancer care vehicle is a symbol of access and early detection with the help of Dr. Sharat Adamki. He's been a part of us for the past 1 year, and the cancer family for 1 year now. We've got into a lot of projects with him, and it is through his initiative that this vehicle has been given to us, come to us through the MP Lab Fund. Thank you so much, sir. Now I request our Honorable Health Minister, Shri Vivanta, to kindly flag off the vehicle. Please proceed with the thing.
Hold the hand.
Thank you so much, sir. And may this vehicle be a beginning of the journey.
But he never came to the finance.
Sir Chituri, Sir Yanthan, and all our DHS and the Director Shillong Medical College, Director IPH, Director Nigrams, our special invitees from outside, Dr. Sharat Adamki, Dr. Ravi Kanand, Dr. Chinna Babu, for being here and sparing your time coming from so far. And also our special invitees, our delegates, all our doctors and nurses, and all the other dignitaries from the health department. I will not be able to name. Thank you for being present here. Today, the 4th of February, is a significant occasion as we celebrate World Cancer Day along the 2nd Meghalaya Cancer Conclave 2026. This day reminds us of the courage, resilience, and compassion that defines the ongoing fight against cancer. Guided by this year's theme, United by Unique, we reaffirm our shared commitment to advancing cancer prevention, early detection, and quality care. Before we begin, I would like to request Dr. C. Young Rai, the Joint Director of Health Services and the State Nodal Officer of NP-NCD, and also the organizing chairman of the 2nd Meghalaya Cancer Conclave, to kindly felicitate the dignitaries on the stage and on the dais and off the dais. So I request you to kindly first felicitate our Honorable Health Minister. Ma'am, next I request you to please felicitate Sir Shakil Ahmed. Thank you, sir. Next I request you to felicitate Sir Sambat Kumar. Next, ma'am, I would request you to kindly felicitate Sir Joram. Next, ma'am, I request you to kindly felicitate Sir Chituri. Next, I request you to kindly facilitate our DHS, ma'am. Next, Director of Shillong Medical College. Ma'am, next, Dr. Sandra Albert, Director of IIPA. Dr. Chinna Babu from the Grace Cancer Foundation, Hyderabad. Next, Samashri awardee. And he leads the Northeast Oncology team. You gave me this one too. Next, Dr. Sarat Labs and Ojaska Labs from Hyderabad, Telangana. And he has been the one who has facilitated a cancer care vehicle which has reached us. Thank you so much, ma'am. I would now like to request Dr. Joram Beda, the Commissioner and Secretary Health and Family Welfare, Government of Meghalaya, to kindly give the welcome address.
Thank you, Anisha. Very good morning to all of you. Honorable Minister, respected Chief Secretary, respected Principal Secretary, my colleague Ramkrishna, my colleague Dr. Balas Momin, all the senior officers on dais, off dais, all the dignitaries, members of the press. I extend a very warm welcome on behalf of the Health and Family Welfare Department to this second Meghalaya Cancer Conclave 2026. It's a profound experience today to welcome all of you, and I request each one of you to please participate with your wholeheartedness. Yesterday we had the technical session, and today also we are having a good lineup of resource persons. We appreciate the effort that each one of you have put to attend this program. The theme for this cancer conclave is prevention and awareness, early detection, treatment and care pathways. Basically, the theme for the conclave itself summarizes what is the intention of the conclave. We are glaring at a near epidemic proportion of cancer. Yesterday in the technical session, we saw that Meghalaya, in terms of the incidence of cancer, is the highest in the country. For a population that small, and to have a ratio-wise such huge numbers is a matter of great concern. And that's why we are all here. Conclave such as this is not only to sit and listen to the resource persons, sip tea, have lunch and then forget. The main purpose is to reinvigorate and also to motivate ourselves that our fight against cancer is a long way to go. So with this, I again extend a warm welcome to all of you. I hope you will enjoy this conclave. Thank you.
Thank you so much, sir, for the welcome address. And Sir Joram has always been, he is also, yes, I forgot, he's also the Vice Chairman of the State Cancer Society, and he has been instrumental in all our plans. Before we bring it forward, it is his help and support that has helped us, bring so many projects to the society. Now, leadership and action go hand in hand. Visionary administrators turn cancer policies into meaningful change on the ground. It is my privilege to call upon a visionary leader, Dr. Sampath Kumar, our Principal Secretary, Department of Health and Family Welfare, Government of Meghalaya, and the Chairman of the State Cancer Society of Meghalaya to deliver the chronicle of Meghalaya's journey in cancer care so far. Sir.
First of all, I would like to place my gratitude and greetings to our Honorable Minister, who has been our Chief Guest for this State Cancer Conclave, and also our respected Chief Secretary, Sir, Dr. Shakil Ahmed, and all the colleagues, my colleagues, Commissioner Secretary Health and MD NHM, DHS, and all the other PA directors and those who have come from, in fact, again, from far away, like Professor Kannan from Assam. He's a very renowned oncologist, I think I don't require to tell about him, and he's been here. And also Dr. Chinnababu, he's again a very young oncology surgeon who has been doing very good work, and in fact in the recent Northeast Conclave organized in Telangana, we have signed an MOU with the foundation that he has set up called Grace Foundation. And of course, Dr. Sharath, I think already mentioned by Dr. Anisha, our member secretary, who is also come. In fact, he has been helping us with the new technologies, like how actually we can use it for better cancer outcomes. And done, and the director IAPH, and everyone, all the doctors and all the everyone who is present here. And we are also missing our Honorable Chief Minister here. In fact, our Honorable CM, Shri Konrad Sangmaji, supposed to have been here. In fact, this was organized at his behest. In fact, he said, he told us last year itself that we should continue to have this cancer conclave every year, just to see like what we are doing, are we doing well, and what needs to be done. We should also invite experts from different places, to see that what actually we can learn from the best practices and how actually we can improve the health system. So it was his vision, our Honorable CM's, sir's vision, who through, because of which in fact we organized such a function. But unfortunately, in fact, because of the he had a sudden meeting with the Honorable Finance Minister today, so he had to leave yesterday evening. So we are missing him, but his message will be there in the video that actually which will follow after my speech. So I think just can you just go to the next slide, please? Yeah. So I think just like putting some slides will be helpful, so that everyone, because all the experts have come from different places, so you can also see like what is the Meghalaya's cancer scenario. In fact, as my colleague Dr. Joram has initially mentioned, cancer, actually East Khasi Hills ranks 2 in terms of cancer among males. That means like if you go for every 1 lakh population, about 227.9 cases are found in East Khasi Hills alone. So that is why the importance of working on this cancer mission is all the more important for the state of Meghalaya. So I don't want to give all the data, but like I want to tell you what are the systemic gaps. In fact, systemic gaps is we have the late detection, because again cancer, if you can actually detect early, we can actually save the lives. For example, cervical cancer, we know actually how actually if you detect early, if there is a you can actually no women actually will suffer from cervical cancer. Similarly with the breast cancer, similarly with so many other cancers, so it is something very important. That's one gap that what we have. And still a lot of cancer, before starting the cancer mission, like what in Meghalaya, the still lot of operations are only in Shillong available. Districts actually, even the diagnostic services are not available in the districts. Then there is a lot of stigma around cancer. I think why it's a very tough. In fact, the screening, even people go, the screening, people are not coming forward. So that's another very important. A lot of mental, like the kind of a stigma, a lot of cultural, socio-cultural barriers. So this is something that we also don't have cancer registry in some parts of the state, like in Garo Hills. So that also was a missing thing. Next slide, please. Can you have this? I can actually operate from here. So just like again to take you through different the systemic challenges. One, we have high cancer burden. We also have we also have these difficult terrain and and referral gaps. And so I just don't want to take this information, but can you go to the next slide? So the So the other thing, just I wanted to show you here, one small incline study we have done recently. One study was done in East Khasi Hills, where we found actually while frontline functionaries are actually referring only 1.6% of the cases, but actually when we have gone door to door and we found, in fact, almost like a 39% should have been referred to the screening. So point is that there's a lot of there is a need for more rigorous screening. So that's again a point that actually what we are trying to say is that how actually we can improve this screening. So taking all this, in fact, I also want to tell all of you that our state government has brought a state health policy in 2021 with three-dimensional health policy. One, we should not only focus on curative part, but we should also focus on preventive part. So that's something that the state cancer mission that has been launched in the state of Meghalaya is essentially to provide that kind of a preventive and enabling support for the state systems to see that that's why this state cancer mission was when it is launched. Basically, this is again a dedicated mission which has been set up with a dedicated state support, and essentially to see that we actually focus on early detection and prevention strategy. So this is again this has the state cancer implementation committee, in fact which has we have recruited a dedicated healthcare personnel, public health experts, and in every district we have again only for cancer screening and prevention we have a separate team is there, like AIDS for HIV, like a MAX. I think you all aware, Meghalaya AIDS Control Society. Now for state we have a dedicated cancer mission is there. This is a very, very important systemic measure, so that because through normal, as I mentioned to you, through regular screening we are not able to actually do the proper screening. So we really wanted to have a more specialized approach. So basically what I just wanted to tell you is that some of the screenings, how it's really happening. You must see people who are coming from outside, in fact especially from Grace Foundation and all, you can see how this is the kind of a condition. 7,000 villages we have. We are one state which is a very geographically tough. So this is the way actually our frontline workers have to go and screen patients in almost 25% of the villages in the state. It's so that's so this is the kind of a work that actually Dr. Anisha and team, very, very committed team, that now that we have got a team here and they're actually going different facilities, and even in the opportunistic screening we are getting a lot of cases. So that is something that I want to do. It's not like an opportunity screening. It's not like a screening that we are actually calling very, so that's something that is happening. So then, as I said, we also actually started, they're doing a pilot in the state, first time in the, in Northeast. We are HPV screening initiative, which is being launched, in fact, which is going to be started. That's why today actually we are going to take this decision on that. And we also have a dedicated, cancer hospital run by the state government. Of course, Negrims has a good facility. In fact, Dr. Vikas is also here from the Negrims, and Dr. Khaled from Negrims. Both are doing extremely good work. And along with that, state government also has set up. Now, currently, though it is 75 beds, already 120 patients are there in the hospital. So that itself shows that there's so much demand. So we're actually expanding it to another 200 bed hospital, which is going to happen within 6 months to 1 year. So that's again a new work. And we also have, so we are getting some new technologies, all this cancer hospital is getting. A linear accelerator is also coming up along with the things that have come up in brachytherapy. These were not there earlier. I'm just saying all these are actually new. Again, the procurement process took us almost more than 1 to 2 years to get that the linear accelerator and all that. So Garo Hills. Now another thing, as I said, we wanted to really set up support systems at Garo Hills and Jaintia Hills, and so that Garo Hills, medical college is coming up there itself. Actually, there is a cancer wing is going to come up. That's another area. So this is something that I think there is Dr. Sharath is going to give a presentation. But again, we are first time in the country. We are actually doing this, using this VR technology to provide better cancer outcomes for the patients. In fact, he will show you the results, how it is actually happening. It's a very interesting study. In fact, we are designed such a way. In fact, even IIPH, the professors are also there involved in this. So here, then at the and just I wanted to show you here. Besides prevention, state is also putting a lot of resources on treatment now. We have, I think Meghalaya has one program, I think for all of you are aware or not, we have a universal health coverage. That means every person, every household actually can access health insurance, not only the BPL households. So this is very, very interesting. That's why, since universal health coverage, Meghalaya is one of the very few states in the country to provide that universal health coverage. So as part of that, a lot of people are actually provided this support. In fact, in the last policy that alone, you can see we spent almost 47 crores, 45 crores, close to 45 crores on cancer care. So this is on the treatment part. So, and how actually we spent on a different, medical oncology, how much palliative care, radiology, and surgical. You can see that how actually the money has been spent here in this state. So that's something I think Professor Kannan also can see, like how actually we can really strengthen our systems here. So with this, I wanted to thank everyone, and basically today we are here essentially to to really to know from each other and to have a strong resolve that we really have to stop this cancer, because it's a lot of cases are preventable cases. It requires a lot of lifestyle changes. We require a massive community mobilization, like what the government of India calls it Jan Andolan. That means like a massive community mobilization is required to see that we are because everyone knows that, should know about it. In fact, if you go and visit cancer hospital in Shillong, you will find, if you ask any patient, just randomly, if you ask, they say that yes, we consumed lot of the betel nut, that is squai, and then we had this problem. So we know that what is happening, the connections, what is and how actually we can really mobilize, because Northeast is one place which has the highest cancer burden. Case fatality rate ratio, that's called, basically number of cancer cases in a particular period versus number of deaths. It is highest in the entire India, Northeast. So it's a very important that we bring this kind of things. For that, we have these village health councils have come up in the villages. So a lot of work we are going to do with village health councils, while this cancer mission not only actually focuses on screening, but through comprehensive primary healthcare approach, we wanted to really strengthen that entire village health councils, proactively changing the lifestyle changes among the population is very, very important. That we have realized that one. And thank you very much for all your participation, and we hope to have a very, very fruitful discussion during this cancer conclave. Thank you very much.
Thank you, sir, for mapping the cancer journey of the state from challenge to change. I know the journey, the road is very long. It is not an easy road that we're going to take, but joining hands, working together with all the stakeholders, I know that one day we will be able to overcome this challenge, and Meghalaya comes as victorious in this war against cancer. Ladies and gentlemen, for years the statistics regarding cancer in our state have been a cause for concern. But today we move past the concern and into action. VR allows us to step into a world where cancer is met with innovation, compassion, and possibility. At this moment, I am pleased to welcome Dr. Sarat Adanki, Chairman of Smrata and Ojaska Labs, Hyderabad, to share his insights on the stepping into the world of virtual reality, a new hope in cancer care, highlighting the transformative role of virtual reality in cancer care. We already have a pilot project ongoing in our cancer wing, where we are using the virtual reality as a form of palliation to help patients tolerate the chemoradiation. So we are almost 50% of the patient recruitment is done, and we hope to be able to present the data to the world very soon. Sir, Sarat.
Shillong, Ramkrishna sir and everybody for giving us this opportunity to be a part of this journey, the healing journey. I quickly can give my background. I run a software company in Silicon Valley. My mother passed away with cancer in 2015. That's when I decided that I got to do something about my contribution towards this healing journey. One thing she told me before she passed away is, at least save one person from going through the side effects which I went through. So that's when I started. I went back to college. I did my 5-year Ayurvedic doctor course, and also I did my health and nutrition from Cornell, and I also studied on mind and body, how it impacts cancer. So that's my background. Using all the combination of these three areas, one of the focus areas our company and organization does is how can we prevent and how can we also reduce the side effects of chemotherapy, radiotherapy and surgery, so that the will to live. One of the key things in any cancer journey is the will to live. When the side effects are so much, when the person is going through day in and day out, that much of a suffering, their strength, the inner strength goes down. When that is not there, the rest, whatever we do, it is just, I would say, it is for, I would say, formality. So that's what our focus areas is. Venkat?
So this one is downward. Just downward. Just downward.
So while they're bringing up, let me, from my memory, let me bring up those slides. So I read a book called A Psychological Study of Cancer. To my I was so amazed that this book got published in 1926. It's a psychological study. And what I learned from that is one of the core reasons is also the emotional blocks, the mind-body connection of cancer. In 1926, again, there is only one book in the world that is in Stanford Library. Fortunately, I got hold of it. What that study says is, especially women with emotional blocks, they studied around 100 women in North America and UK. Out of those 100 women, they figured out that most of them have some kind of an emotional trauma. Because of that emotional trauma, they somehow directly, indirectly, they were detected with cancer, especially in the reproductive organs, breast, uterus. Now, the study went further and they also talked to these people, these women, and further got into some more deeper, can you go to the next slide? Next one. Yeah. So this is the book. So they talk to these women and they ask them what is that they're doing about this emotional trauma. How are they taking it out? Did they really recognize and acknowledge that they have this emotional trauma? 50% of them, they've acknowledged. The women who acknowledged and went through their cancer journey, they figured out that the relapse they recovered. The women who did not acknowledge the fact that they are going through the emotional trauma, in fact, the relapse happened and most of them passed away. So the first thing which I want to tell everybody is acknowledging our emotional blocks, our emotional trauma. Somehow taking it out is very, very critical in any healing journey. Now, how this is linked to cancer? This is one of the causes. We got to acknowledge that stress, the modern life, especially women who not only runs a family, these days they are also professionals. How do they balance it out? So one line is self-love. When we love ourselves, especially when you fly an airplane, they say use the oxygen mask before you do others. The same thing example is applicable for everybody. A guided imagery session, I took them to a peaceful setting and to a mountain, and where I took them into a nice cabin where there's a fire going on, and I asked them to relax in that chair. I checked it, within 5 minutes, it was less by 30 points. So there is a role of mind. That is what we are trying to do. That we've converted into a 360 degrees immersive videos, ported onto a VR device, created a beautiful launch, and these people, they're coming and sitting in these long chairs, wearing these devices and taking chemo. At least during that 3-4 hours, they're not thinking about cancer, what happens tomorrow, how do I take care of my kids. All that is at least getting distracted. So that is what we are trying to do. Again, during my personal consultation, over 1,000 people so far, I figured out that at least 20 to 30% reduction was there. That's when I thought, let's make this into a scalable solution. Can you go to the next slide? Again, this is what the number says, how many people abandon cancer treatment, and how many more, as you see, even in US, it's no different. Every day we are seeing more and more cancer cases. No, next slide. Go to the next one. So this is the initial results of this study. What we are seeing is an amazing result where the people who are taking these, following this part of the study group are faring better than the part of the control group. Again, this is not complete yet, but I thought at least I'll share the information what we have. Again, I have a large team back in US and Hyderabad. This is being led by one person named Armin Tikerian. He is the CEO of the Ojeska Labs, and we also have Lalita Golamudi. She is the CEO. She is doing pretty much hand in hand running this whole study. And my wife is she's a script writer. She is doing most of the production work. So any questions? Yeah. We're going to do a peer review and we're going to follow those things. Absolutely. Yeah, if you don't have any questions, I have one last thing to say. Sampath sir did mention about it. Cancer is a disease where it's better to prevent it rather than fight it. I would say diet is number one cause. Let's pay attention to what we are eating, how much we are eating. The modern lifestyle, I would say it is excess of consumption rather than malnutrition. So we got to make sure that at least once a month, let's give a light day. Let's try to eat less. Second is inflammation. Third is stress. Fourth is adulteration. What we are putting into our system, we got to have some filters so that we know how much we are eating, what we are eating. Is it genetically modified, or does it have chemicals in it? So if we have to consciously prevent this. Again, and the last one is our lifestyle. At least walk few miles a day, every day, in a green environment, especially Meghalaya being such a beautiful state. It's unfortunate that if you're not walking out in the greenery at least 1 hour a day. And thank you very much for the time and opportunity.
Thank you so much, Dr. Sarath, for bringing the world of virtual reality into our lives. I would also like to mention to the audience that we have the next hall where stalls have been set up for various activities that we are undertaking. And one of the stalls is of the VR device. So if any one of you want to have the VR experience, we have the stall, the launch there. You can go ahead and experience. We also have in the stall the breast screening device, AI-based, the Niramai, which is also there. So anyone who wants to get screened for breast cancer, please go ahead. There is a stall for breast cancer screening also. And also we have a stall for HPV screening where they were going to explain from Roche Diagnostics where they're going to explain to us about the importance of HIV, show us the procedures, how it's going to be done. So please take the opportunity, and you can during the break, during the lunchtime, please do visit the stalls. And we also have a lot of pharmaceutical companies with their stalls there. The next session is deeply meaningful and inspiring. We are honored to have with us a courageous cancer survivor, Gordon Jirwa, who suffered from cancer supraglottic larynx. He was diagnosed with cancer in the year 2025, approximately in the month of May, June. He was referred to us and through his cancer journey, he has completed his treatment in December, declared cancer-free in December, and he is here with us to share his cancer journey, his experience of his personal journey of strength, resilience, and hope, reminding us of the power of the human spirit to overcome even the toughest challenges. And he is also one of our patients who with chemoradiation also had the opportunity to experience the VR treatment along with it, and how it helped him in going through the journey, because cancer treatment is not easy. It's not like any other treatment where once you are treated, you're free from all the pain and all. The diagnosis itself is painful, and the treatment is more painful and more difficult. So, Gordon, I request you to please come forward and share with us your journey through cancer. Let's give him a big hand of applause for agreeing to come and join us here.
Good morning, everybody. Nung sa ang kan kasi mo, so nung sa ang ngo yo play try kan dang wa ang poi hat on ko put ti ta ngai play visa broไปวันทางนี้ti doctors bawila health minister ti in the two years panga journey jonga hapoka ting sumare cancer mo nung ka jiksam jonga ka along the symptoms jonga bayo kade some difficult on the throat kadon problem that I thought it was a fish bone, so I eat a lot of thick rice. When the fish bone is stuck, you used to eat this thick rice. It's not working. Then what I do, I try to consult my nephew. He's a doctor. He's a medicine doctor. He said it might be a gastric. The gastric shoots, sometimes in the neck. So I thought it might be that. So I went to the general medicine doctor. He said that. Then I explained him everything. The general medicine doctor sent me. He referred me to ENT doctor. Then I refers to ENT doctor. Tinggal alek, he don't specialist. To the ENT specialist, they refer to the way try the gastric. So the way it's not helping. For 1 month, it's not helping. Then I'm worried. I did not do. Again, I came after 15 days. Then I came again and explained it's not working. So he said, okay, let's do this. We'll take some video endoscopy and we'll take some biopsies from there. I didn't do a biopsy, endoscopy, and they take something from my neck, it's a biopsy. They didn't do your report, and then the doctor didn't say me anything. Some batay nga ba kadikiki. I didn't do I didn't let yung doctor, what is this? What does it mean? Please explain me. Then he doesn't say anything. I didn't do, no, you have to do a CT scan test so that they'll make it clear. Ngayon nga pinino report sa po kibahin sa mga doctors. Report ko kani kadika pre-cancers. It may be first stage cancer, I don't know. It's like that. Ngalit nito ang doktor kung kamatayin mo it's cancer. So you have to go to cancer wing. Refer us to oncologists. Tingnan mo, I'm shocked. But I'm not panic. I didn't know what happened. I don't know. Kung ba katiga tang late na ituloy ni doktor ako cancer wing tikila patayan nga kung makatiga tam tapos yung gilek test kini tayo kilala test pa kilala to dang treatment on 27th of May. That was my first cycle of chemotherapy. The first cycle the Nabiang comment na second cycle, Nabiang third cycle I was a bit weak, but still I'm fighting. After that, once radiation therapy, and radiation therapy is quite tough. It's kapanong stomach brio. But still, you should have that strong feeling. That you have to fight. You have to be strong. Otherwise, if you won't be strong, then ki doctors ki janjar ban help you, no? They have long kajumbu jumperkat, jumpi pin have long climb, pin have long very strong. You have to fight. then after that, after my radiation therapy, for 42 days, I couldn't speak. I have to put a piece of paper to tell anything what I want to my wife, and for my friends, I just take a text in the mobile. And on the 17th of October, I remember, and everything is get up. I said, "Hey, everything." And it's so free, it's so relief. So it's very tough. I say cancer, it's not that easy. It's a kind of disease, it's quite tough, but you have to fight. You trust in the doctors, in the nurse. And I like to thank the civil hospitals. You see, you cannot underestimate the civil hospitals also because it's quite tough now. Civil hospitals is quite tough. And regarding that time, treatment, the daycare, we used to New York, VR, no? So before my, it's really good. It's really relief. It's out of stress, relax. Kalau perba, jumpa perkat, kan like nak attention, everything. So that is my journey, and it's not so easy. But if you love yourself, that's all. That's all I have to say. Thank you.
Thank you, Pak Gordon, and you've really fought the fight, you've won it. And I would request our Honorable Health Minister to kindly felicitate Pak Gordon, who is our cancer champion, and he will always reflect, and he will be an example, shining example to all our other patients who will be detected in future, present, undergoing treatment, to fight this disease and win it.
Really want to congratulate the entire team of Health Department, led by Minister, Principal Secretary, and each of the foot soldiers who are working in the field, in the far-flung areas of the state. Honorable Minister, Principal Secretary, Joram, Chituri, Madam Momin, Anjana, and Dr. Chinnappa, Dr. Ashwin, Ajay, Madam Sandra, Director, other esteemed oncologists from different institutes. Galaxy of people are here, and many of you have done excellent work in the field, which is evident by the way we have seen. My mother is a cancer patient. I wish I knew Dr. Ajay earlier. Last year she got detected, and Dr. Sharad I knew earlier because, whether we like it or not, we can always speak that there's a stigma, we want to remove stigma. But once that comes in the family, it's good to preach, I'm not blaming that. It's very difficult to handle the moment you detect and realize it. It's not because there is anything bad about it, but the first thing your parent will ask, why me? What have I done? I haven't drunk, I haven't taken chew, I haven't taken tobacco, I was living a whatever normal life, why me? See, the biggest challenge in cancer is basically a denial. So the preventive aspect which government we are doing quite remarkably well, considering the challenging terrain we have, accessibility we have, and difficulty of reaching, as Sampath earlier mentioned, 7,000 of odd villages, which even some of the villages we need to really walk long distances. Still our people are reaching. Even after reaching, there will be an element of, because people are scared of it. Even within a campus, you can always say, people don't even say relative of a cancer. They just whisper, C. And in the colleges we are taught CA. The patient you detect, you say that she suffers from CA. Similar to that, there is a whisper among the corridor that somebody's sister is suffering, somebody's mother is suffering. That much is unfortunately the taboo around cancer. So that, of course, like Gordon mentioned here, we need champions to break that taboo. We need people to say that post 66, 1 out of 2 is likely to get cancer. When the longevity is more, cell crosses the cycle of its existence, definitely some of the cell or telomere will trigger and multiplication become either somatic or it will multiply and you're bound to get cancer. So it is not, as we live longer, the propensity for having cancer in the society is more. We can't deny that fact. But how do we handle it? As earlier mentioned, definitely it is prevention if we can do that, or at least an early detection. Because any patient you go to an oncologist after stage 2, first thing he'll say is that, I wish you had come earlier. Every patient you go, definitely in cancer stage 3, always will think, I should have done a test. Many a time I had occasion to do a HPV, I had occasion to do a surveillance test, I had occasion to do, but I didn't do. There are 2 reasons. People generally think, I won't get cancer. Why should I get cancer? That is a general thing that, Arre, humko nahi milega. So, this is one of the biggest reasons people who have unexplained hemorrhage, people who have either sort of limbs, people who have dysphagia, eating disorders, they always justify saying that no, it can't be cancer. And that leads to many occasions detection very late stage, which you regret throughout your life. The second thing is people think that what if I get diagnosed with? If I test, I may become cancer. See, both are definitely dangerous. It is better to be realistic and better to be empowered than fearful. So we need to have a massive awareness. As Sambat mentioned, community, school, colleges, youngsters, NGOs, whoever may be, we're all part and parcel of this journey which mandates each one to understand that it is a thing we have to live with, and early you detect and better you become, and early you detect, there's a better life left for you. And that is the only way to address cancer once it is diagnosed. Far better, of course, is prophylaxis is always better than cure. We all know that. And for which the etiology of the cancer need to be really addressed. In our state, I'm sorry to say, I think the tobacco in various forms of the chewing, we really need to address to the core, because probably more than majority of cancer in our state is because of that. So across the spectrum, community, we need to really work an anti-tobacco campaign intensively. I think to the extent, I think we have a timeline to work on to address this issue, because otherwise we are doing a sin for our coming generation. Having known about it, we should be acting collectively with our mission and a decision and a determination to finish that. I once again urge each one of you, having come from different parts of the country, to participate and collaborate. Thanks to the bottom of my heart in person, as well as from the department and from the government of Meghalaya for you all have come and share your ideas. To my esteemed doctor colleagues here from my state, this is an opportunity for us to learn and understand and widen our horizon and to use it for the welfare of our community and society. Once again, I congratulate the entire team for working for this and other teams for collaborating, the MP for contributing the vehicle, and the whole team, Dr. Chinappa and everybody, for having come and collaborated with us. Thank you very much. Kuble, Mithila, Jai Hind.
A very good morning to one and all present here. Respected the anchor of today's second Meghalaya Cancer Conclave 2026, Dr. Anisha Maulong. Respected dignitaries on the dais, our hard-working officer of the government of Meghalaya, our guest of honor, the Chief Secretary of the Government of Meghalaya, our Principal Secretary, Commissioner Secretary, our MD of NHM, the directors of different from the health department, our health warriors who who is working tirelessly on the field to provide quality healthcare to the people of Meghalaya, all the expert resource person invitees from different parts of the country. At the same time, I'd like to thank especially Dr. Sarat Adanki, the chairman of Smata and Ojas Kalap, and especially for your effort. Through your effort, today we could flag off the vehicle. And also through you, I'd like to thank Shri Vijayendra Prasad, the Member of Parliament Rajya Sabha nominated from Andhra Pradesh, for his valuable support. As we know that Meghalaya, it's not an easy to reach, especially because of the terrain. So through your support, especially with that vehicle we flagged off today, I hope it will be a blessing for the people of our state. We gather here on this second Meghalaya Cancer Conclave 2026 under the theme United by Unique. It reminds us that every individual affected by cancer has a unique story, a story shaped by their biology, their culture, and their struggle. But while the stories are unique, our response must be united. I stand before you today, not just as your minister, but as a fellow citizen, deeply concerned by a shadow that loom over our beautiful hills. We cannot shy away from the hard truth. The national picture is alarming, with over 1.56 million new cases in India annually. But for us in Meghalaya, the alarm bells are ringing louder. Our state stands out, unfortunately, for having one of the highest age-adjusted cancer incidence rate in the country. Statistics tell us that for every 1 lakh men, nearly 177 are affected in our state, compared to the national average of 100. For women, it is over 96. In districts like East Khasi Hills, the burden is even heavier. These are not just numbers on a spreadsheet. These are our fathers, our mothers, our brothers, and our sisters. We must ask ourselves why. The profile of cancer in Meghalaya is specific. We see a high prevalence of cancer of the oral cavity, esophagus, and hypopharynx. Science tells us these are closely linked to risk factors we can control, such as tobacco and alcohol. But there is a second silent enemy: late detection. Data from NFHS5 reveal a painful reality. The screening uptake in our state is extremely limited. Only 0.6% of women aged 30 to 49 have been screened for cervical cancer, only 0.5% for breast cancer, and for oral cancer, merely 0.4%. This is the critical gap. It is not a lack of medical knowledge, it is a gap in awareness and hesitation to seek help. To bridge this gap between hesitation and healthcare, the government decided to take the first step. In the last 2 years, we launched a pilot program for cancer screening across the state. We successfully carried out 2,342 screenings. However, this scam revealed a paradox that we must address today. Out of these 1,000 screened, we had 28 cases of early detection. Now, you might ask, is that number low? The message here is critical. In spite of the cases detected in the camp being high, the early stage detection was low. Why? Because our people are not open to routine screening. This is a culture of silence. People report to health facilities only when the pain becomes unbearable, only when the disease has reached an advanced stage. We wait for the symptom to scream before we listen to our bodies. The mindset must change. Screening is not a sentence. Screening is a shield. We must normalize walking into clinic when we are healthy, not just to be sure. The government is committed to ensure that when you do seek help, the best care is available right here at home. We have launched the Meghalaya Mission for Cancer Prevention and Early Detection, aligning with the National Health Mission for Cancer Care. We realize that early detection means nothing if treatment is unaffordable. That is why we have upgraded the dedicated cancer wing at Civil Hospital Shillong with increased bed capacity for 200. Today we provide comprehensive services, free chemotherapy, free radiotherapy, and cancer surgery. Linear accelerator machine, brachytherapy machine, and CT stimulator machine are under installation and will be operationalized. We have backed this with the Meghalaya health insurance schemes to ensure that financial hardship never become a barrier to life-saving care. For many families, this has meant treatment closer to home, fewer trips outside the state, and the dignity of being cared for near their loved one. Does this approach work? Yes, it does, and I have proof. Let us take a look at a cancer survivor, Riyaka Nongse. Riyaka Nongse is from Nongstoin, Meghalaya. Her journey with cancer began very early in life when she was just 9 months old. In 2016, her family noticed something was not right and took her to Woodland Hospital in Shillong. After medical evaluation, Riyaka was diagnosed with a germ cell tumor involving the back, a rare condition. Understanding the need for specialized care, she was referred for Civil Hospital Shillong, where she was registered on 10 November 2016, aged 1 year and 9 months old. Despite her tender age, she shows remarkable resilience. At Civil Hospital, Riyaka underwent chemotherapy as advised by the treating doctors. She completed all her prescribed cycle of treatment under careful medical supervision. The journey was challenging for both the child and her family, but with timely intervention, dedicated healthcare support, and continued follow-up, she responded well to treatment. Today, Riyaka is 11 years and is in class 6. Continue to visit Civil Hospital Shillong for her annual checkups. Each visit stands as a quiet reminder of how early detection, accessible cancer care, and sustained follow-up can change the course of a life, even that has just begun. Her story is one of hope, strength, and the importance of early cancer care in Meghalaya. Also, I want to share a figure that filled me with hope. We have 377 success stories in the past 2 years. 377 individuals who have looked cancer in the eye and won. Here is the most important lesson from these survivors. Out of these 377, 25 were detected at the early stage, but the remaining majority was detected at stage 3 and stage 4. How did they survive? They survived because they completed all the treatment without any gaps. They trusted the doctors. They did not give up. This proved that a diagnosis, even at a late stage, is not a death sentence if we follow the medical protocols. Imagine how many more lives we can save if we catch it early and treat it consistently. We have faced difficult health battles before. Look at our fight against infant mortality and mother mortality. A decade ago, the numbers were daunting, but through focused institutional deliveries and community support, we have been able to significantly bring down infant and maternal mortality rate. We made childbirth safe, now we must make aging safe. What is required to fight cancer? The same spirit. We need the same community mobilization. We need our ASHAs, workers, our headmen, and our religious leaders to talk about cancer screening just as they talk about immunization. We need to move from saving the child to saving the family. Looking ahead, we know there is more to be done. We must be honest about our tertiary healthcare system. Currently, the burden falls heavily on Shillong. This creates a bottleneck. To improve our tertiary care, we are moving toward decentralization. We envision a Meghalaya where quality cancer care is not limited by geography. For this, we are expanding infrastructure. We are working to upgrade district hospital so that screening, diagnostic, and basic palliative care happen at the district level. Secondly, for human resources, we are investing in oncology-trained human resources. We need more specialists, more nurses trained in chemotherapy, administration, and more technicians. And thirdly, referral network. We are strengthening the pathway so that a patient in a remote village is seamlessly guided to the right expert without getting lost in the system, and even providing traveling allowance for whole treatment in addition to their diagnostic and treatment. Ladies and gentlemen, we have spoken about the challenges, the data and the vision, but a conclave is not just a place for discussion. It must be the launchpad for action. We cannot wait for tomorrow to fix the problem of today. Therefore, to turn our vision into reality, I am proud to officially dedicate 4 landmark initiatives to the people of Meghalaya today. Firstly, field implementation of Meghalaya Mission Cancer Prevention and Early Detection. First, we are moving from policy to the pavement. I am pleased to launch the field implementation of Meghalaya Mission for Cancer Prevention and Early Detection. What we are expecting, the impact. This marks the moment we take the fight out of the conference room and into the villages. It is our promise that government will no longer just wait for the patient to come to us. We are marching to the doorstep of our people to find and fight the disease. Second, cancer screening app and devices. To empower this mission with modern tools, we are launching the cancer screening app and advanced diagnostic devices. What we are expecting, by placing this cutting-edge technology in the hand of our frontline workers, we ensure that the data travels faster than the disease. This will bridge the gap between screening and treatment, ensuring that no patient is lost in the paperwork. Thirdly, statewide HPV testing initiative. Keeping the health of our mothers and sisters at the forefront, we are rolling on the statewide HPV testing initiative. Cervical cancer is prevalent, and with this initiative, we are building a protective shield around the women of Meghalaya. We are moving from reactive treatment to proactive prevention. Fourthly, project with Grace Cancer Foundation, Hyderabad. Proving that we are indeed united by unique, I am delighted to launch the collaborative project between the government of Meghalaya and Grace Foundation, Cancer Foundation, Hyderabad, specifically for cancer control in West Khasi Hills. This partnership brings world-class expertise to our hard-to-reach areas. It is a symbol of our resolve that distance and terrain will no longer be an excuse for lack of care. These 4 initiatives are not just programs, they are pillars of a healthier Meghalaya. With this step, we reaffirm our pledge to every citizen: you are not fighting alone. Let us move forward with hope. So, before I conclude on my closing remark, once again, as we have seen, this is not for the first time. Meghalaya, like I've already shared, we have been facing the problem of high MMR and IMR. As we have did, today we stand the numbers below the national average. So this, I think, since we have done it, so there is no problem for us if we work together in order to fight this another dreadful disease which are affecting our beloved state of Meghalaya. But I would like to urge, especially to our team, that I want to see that this kind of program should not end up only in conference hall, only in good presentation, but I want to see things happen on the ground. That is very much important. And as we already mentioned, that the most important thing is early detection. And for that, we need community mobilization. So today I could see that there are very less participation from the community. So I would like to urge that in the coming days, for such program, I would like to see our Sinjuk of Rangbashnong, the Association of the Nokmas, all our religious head, and so on. I want to see them coming and participating, because they are the people on the grassroots. So I would like to see that in the coming futures that they would be present in such important programs. And also I'd like to urge that this kind of program should not end up only in cities or in Shillong. I would like this kind of program to be held in different districts, in Jowai, in Tura, in Nongstoin, in Nongpok, and so on, in order to reach to the people. So with this few words, once again, the theme United by Unique is a call to arms. To the medical fraternity, continue your noble work. We will support you with infrastructure. To the citizen, do not fear the screening, fear the silence. To the families, support the treatment, do not let the gap happen. We have the tools, we have the mission, we have the insurance support, and as seen in our 377 survivor, we have the resilience. Before I forget, I would like to thank Bak Gordon also for coming and joining with us to fight. We know that journey has been very challenging, and I think it's the best for the people to hear to the person who have faced it. So thank you for coming and sharing. And like I already said, please keep on sharing, because this will give encouragement to the other people to come forward for treatment. So with these few words, let us pledge today to build Meghalaya where cancer is detected early, treated effectively, and defeated courageously. Let us turn our unique stories into a united victory. Kublai Shibon, Methela, and Jai Hind.
Thank you so much, sir, and we are truly blessed to have a leader who is not only detail-oriented, but also deeply focused on positive outcomes. And you must be wondering how Sir knows so much about cancer. He's really outlined everything. He would not accept anything. I was on the phone with him constantly. I had to brief him about everything of what we have done, what we are going to do. And he has already instructed me also that I have to give him detailed report at least every now and then of our mission also and how we are performing. So thank you so much, sir. I would like to request, sir, the launches that sir has announced. Of course, we have not been able to bring the devices here, but on the screen we would like to launch it, and I request our Honorable Health Minister to kindly do the screen launch of all our launches that will happen today.
Introducing the Cancer Screening Mobile App. This isn't just technology, it's a lifeline designed to streamline risk assessment and patient data. It makes early detection accessible and fast. We are bridging the gap to better health with a single touch. Next, our state-of-the-art thermal ablation devices will be available across all districts. This portable technology allows for immediate treatment for precancerous lesions right at the point of care. It is fast, minimally invasive, and stops the disease effectively before it can even begin. A major step for women's health, the statewide HPV testing initiative. We are moving from reaction to prevention by rolling out testing across the entire state. We are ensuring that every woman is protected against cervical cancer, leaving no one behind. Finally, a landmark collaboration. The Government of Meghalaya joined forces with the Grace Cancer Foundation, Hyderabad, focused on West Khasi Hills. This project combines government reach with expert care to bring comprehensive cancer control directly to the community.
Please be seated. Thank you. Thank you so much. Everyone, please be seated. I would now like to call upon Dr. C. Yangrai, who is the Nodal Officer for NP-NCD, to kindly, we have another announcement. We're going to felicitate the best performing district.
State NCD cell and the National Program for Non-Communicable Diseases. Through our district teams, our nodal officers are also in the audience today. We are instrumental in providing activities under the National Program for Non-Communicable Diseases. Our routine activities include screening and for also providing the continuum of care in terms of referral, diagnosis as well as treatment for hypertension, diabetes, as well as the three common cancers, that is oral, breast and cervical cancer. Other than this, we also undertake routine other than our routine campaigns, we also have some special campaigns. So today we would like to announce our best performing districts in two of the campaigns and felicitate the winners. May I request Madam DHS and Sir MD Ramakrishna Chituria, yes sir, to kindly hand over the certificates for the intensified NCD screening campaign. This was conducted during 20th February to 31st March 2025, and the first prize goes to North Garo Hills. May I request the District Nodal Officer and the team from North Garo Hills to kindly receive their certificate. The second prize goes to East Garo Hills. May I request Madam Nibandik and her team. The third prize is shared by two districts. May I request the team from South Garo Hills, Dr. Shini Mara and her team. The third prize is also shared by Southwest Garo Hills. District Nodal Officer, Dr. Mahendra. Many congratulations to the winners for the intensified NCD screening. We are also happy to announce the winners of for the World Hypertension Day's month-long observation of activities between 17th May 2025 and 16th June 2025. The first prize is won by West Garo Hills. Madam Molly Momin and her team, the District Nodal Officer. The second prize is won by West Jaintia Hills. And the third prize is won by Ribhoi District. Many congratulations to all the winners and thank you very much. Over to Madam Yana.
Thank you, Dr. Ashwarya. Thank you, everyone. I think Garo Hills has performed exceptionally well in these campaigns. And please keep up the good work. And as we launch the mission also, we have high hopes that things will pick up in Garo Hills and you will be a winner in the mission also. We'll have lots of patients coming from Garo Hills. Khasi Hills, it's easier. They can come easily. So Khasi Hills, Jaintia Hills, Ribhoi, it's so near. The place, when we went for our field visit, Garo Hills, that I think we'll have to ask them. We will work harder, sir, and next year we will win the prize, I think. We should. Okay, we come to the end of our program, and as we end, we come close to this inaugural session. It is my privilege to invite Dr. J.S. Momin, Director of Health Services, MI, to deliver the vote of thanks. I kindly request her to take the dais and formally conclude the program.
So a very good morning to everyone present here. As we conclude this inaugural session of second Meghalaya Cancer Conclave, I stand here with a deep gratitude to thank our chief guest, the Honorable Health Minister. Thank you, sir, for your visionary leadership and for launching the field implementation of the Mission Meghalaya Cancer Prevention and Early Detection, launch of cancer screening app and devices, and statewide HPV testing initiative. Your presence today, sir, reinforce the government's commitment to making cancer care a priority for every citizen. I also want to thank our Chief Secretary and guest of honor of this program, Sri Sakil Ahmed, IAS. Thank you, sir, for your constant guidance and support towards the cancer health initiative in the state, focusing on early detection and cancer prevention. My sincere thanks to Sri Vijayendra Prasad, Honorable Member of Parliament Andhra Pradesh, for his generous support in sponsoring the Mahindra Scorpio vehicle This contribution is a valuable support to our healthcare efforts and reflects a strong spirit of cooperation beyond state boundaries in the fight against cancer. I would also like to thank Dr. Sarat Adamki for introducing us to the transformative potential of virtual reality in cancer care. It reminds us that while we fight with medicine, we must also heal with innovation and empathy. I also want to thank Sir Dr. Sampat Kumar, Principal Secretary, IAS, Dr. Joram Beda, Commissioner Secretary Health, for mapping out the road from challenge to change. Your data-driven approach is what gives our department the clear direction we need. A special thanks to cancer patients and survivors. You are the reason we are united by unique stories of resilience. You remind us that our work is not just about statistics but about human lives. I would also like to extend my special appreciation to the oncology team of Civil Hospital Shillong, the State Cancer Society of Meghalaya, and the entire organizing committee for their tireless efforts and unwavering dedication. Their professionalism, commitment, and behind-the-scene work have been instrumental in ensuring that this program has been conducted in a well-coordinated and meaningful manner. Last but not least, I sincerely thank our sponsors for their generous support, which has contributed significantly to the success conduct of this conclave. Aureate Healthcare Limited, Dr. Reddy Laboratories, Biomark Laboratories, Neon Laboratories, Alchem Laboratories, Otsuka Pharmaceutical India, Healthstat Pharma Private Limited, Rhodes Diagnostic India Private Limited, and Lupin Limited. Finally, thank you to all the delegates, including community leaders, religious leaders, influencers, and each of us present here today. So let us move forward from this room with a shared resolve that in Meghalaya no one should fight cancer alone. As we move forward from this conclave, let this not remain a discussion confined to this hall, but translate into a measurable action on the ground in our districts, our communities, our households. The success of Meghalaya Mission for Cancer Prevention and Early Detection will depend on the collective ownership, sustained commitment, and timely implementation. So let this conclave mark a turning point where policy meets practice, where technology supports compassion, and where early detection becomes a way of life in our state. With strong leadership, dedicated healthcare workers, empowered communities, and courage of survivors guiding us, I am confident that Meghalaya can set an example in cancer prevention and care. Once again, I extend my sincere thanks to all who have contributed to making this conclave meaningful. Let us go forward with renewed purpose and unwavering determination to build a healthier, cancer-aware, and cancer-resilient Meghalaya. Thank you. God bless you.
Thank you so much, ma'am, for the vote of thanks. And with you as a leader, ma'am, we can do so much. The inaugural function is concluded here, and since we're running short in time, so I would request we'll break for a tea for 15 minutes, and then the scientific session will start at 12:15. We'll keep it so that the scientific session will not run long. So thank you everyone. I thank our dignitaries for being with us. Thank you all our guests from outside, from the state, from the other districts, from other hospitals, from the institutes, other institutes. Thank you so much for being a part of our cancer journey. And as we move forward, we will hold hands and fight this disease together. Thank you so much.
representative from academia, civil society members, media colleagues, and distinct delegates. Very warm welcome to all of you to the scientific program of the second Meghalaya Cancer Conclave 2026. Today's session reflects the true spirit of our team united by unique, where policymakers, clinicians, public health experts, educators, community leaders, nurses, ashas, patient voice comes together on one platform to strengthen cancer care from prevention to policy, from community to cancer care. So let's start with our first session. We begin with today's scientific deliberation with a highly significant session that focuses on moving beyond isolated intervention toward system-level transformation in cancer care. This session, the title of the session is Roadmap to Transforming Cancer Care from Individual Cases to System Change in the Country. This session will be moderated by Dr. Ravikant sir. He's a director of Kachar Cancer Hospital and Research Center. It's an institute that has become a model for comprehensive cancer care in the Northeast India. Sir is also a recipient of Padma Shri Award and also of Ramon Magsaysay Award, the highest award in Asia. And I would also like to honor to have an eminent panel of speakers to come on the dais and also say, sir, can you come on the dais? And I would also like to honor to have an eminent panel of speakers, Dr. Sampat Kumar IAS, Principal Secretary, Department of Health and Family Welfare, Government of Meghalaya, to come on dais. Dr. Joram Beda IAS, Commissioner and Secretary, Department of Health and Family Welfare, Government of Meghalaya. Dr. Sandra Albert, Professor of Public Health and Director, Indian Institute of Public Health, Shillong. Dr. J.S. Moman, Director of Health, MI, Shillong. Dr. Nila E. Karsano, Director of Health Service, MCH and FW, Shillong. Dr. Nicola Carissa Lindo, Young Rai, Director of Shillong Medical College. Dr. Caroline Young Rai, Joint Director of Health Services, MCH, Family Welfare, and State Nodal Officer of MP. Sorry, Dr. Yangra will not be able to attend. So I would like to invite Dr. China Babu Sukavali, MS. He's a senior robotic surgical oncologist, clinical director of Yashoda Hospital, High-Tech City President, and a president of Grace Cancer Foundation, Hyderabad, Telangana.
Ashwarya, Dr. Ashwarya, please join just for.
Good morning, everybody, and thank you for inviting me to be a part of this conclave, and thank you for each of the panelists and to you especially for pulling you in at short notice. We have a very power-packed panel, and so we all know that cancer care cannot improve through isolated excellence. A good doctor, a good hospital, a good program is not enough to transform cancer care, because if the system is not strong, then the whole thing is very fragile. So today in the panel, we will try and not showcase individual programs, but focus on system levers that can make a good cancer care routine rather than an exceptional event. Cancer care outcomes depend more on systems than on individual skill. Delays are usually design failures rather than intent failures. And the Northeast, if all of us agree, require, why Northeast? Every part of the country requires context-specific solutions. I therefore request the panel to focus on identifying system levers, not programmatic descriptions, that can improve cancer care across the state. So can I have the first slide, please? Just to put. This can work. Okay. So good cancer care should not depend on where you live, but depend on who your doctor is. It should be a given. Next slide, please. So just to put the situation in perspective, see, all of us know that the age-specific incidence of cancer in the Northeast is very high. In fact, the Principal Secretary and the Minister and everybody actually, articulated this very well. And so remember, we have to look at this in perspective. It is very easy for us to, think that, we have 200 per 100,000, 176. Yes, it is a high incidence, but then we have a good problem to handle, because our total population, so this is 2024 data, and this data is what I picked up from one of the Lok Sabha answers given by the Health Minister. And so this cannot be very different from what is quoted by this is from the ICMR portal. So in 2024, all states in the Northeast together saw about 52,000 new cancers, and in 2024, of the entire population of the Northeast was under 50 million. So if you look at number, and then when you look, this is crude incidence. Crude incidence and age-adjusted incidence are slightly different. Age, see, as the population ages, the incidence of cancer increases, and so when we look at crude incidence, it's different ages, different populations put together. But then we use a standardized incidence. It could be India standard or WHO standard or US standard. And for each age, the age-adjusted incidence is then calculated. It's complicated. Don't ask me how it is done. But age-adjusted incidence looks far more alarming than the actual incidence rate. So if you look at Meghalaya, for example, in 2024, we saw about 3,000 odd cancers. If you look at absolute numbers, the numbers, 170 per 100,000 in men and 96 per 100,000 in women, sounds very frightening. But if you look at the number, actual number, because our population is not even 40 lakhs. And so if you look at absolute numbers, we see only about 3,000, 3,200 cancers. And even if you look at people who are underdiagnosed, people who are not reported, people who don't come, all that put together also, it won't be more than about 4,000-5,000, maximum 6,000 people. It's a wild guess, but that is all the number that we have. And so, for us, when you look at 170 per 100,000, that is where we could really land up in. But then today, we are seeing 3,000 or 4,000 new cancers every year, and if you look at it that way, it is a problem that we can manage. If we get our act together today, if we put in place systems, we should be able to manage this number without too much of trouble. Next slide, please. This is what I meant. Next slide. And so, I would like us to focus on just one question through the next hour. What must change at the system level for a patient in Meghalaya to receive timely, equitable cancer care, regardless of whether they are in Tura or whether they are in Lagrumbai, or who they meet first? What is that thing and so for each of you, this is what, and in the interest of time, I request each of you to keep your answers short, about 2 minutes, and try to calculate, how much of time it will take. And use one example is necessary. Speak from what you as Principal Secretary or as Director of PHFI, I keep saying that, what each of you can do, and see what realistically can happen. The conversation, we will split into 3 sectors. One is, what is the bottleneck? Why does delay or inequity enter the system? Second is, what is the lever that each of you will control? And then, how can we integrate across silos? So next slide, please. So let me start. Next slide. So I'm asking, so the Director of Health Services, what is the single most important bottleneck in the system?
Thank you. The single biggest bottleneck in the system in Meghalaya is late diagnosis due to weak detection and weak referral system and weak follow-up. And that is
Okay, and the state nodal officer is not there. Can somebody? Yes, ma'am. My same question? What is the single most important bottleneck that causes delay? That is, what is the single point in cancer care where patients invariably get delayed? Why is it that they don't come to the hospital? From your point of view,
Thank you, sir, for the question. So, from what we've seen is that even if people come for, after diagnosis and treatment, when they come to us, and what we've seen is that because they come at a very late stage, so the treatment, they cannot withstand the treatment. So most of them either at first go to faith healers and traditional medicines, and even in the later stage also, sir, like when they cannot face the treatment anymore, they turn to faith healers and traditional medicines.
oh, okay. So, Principal Secretary, sir, what?
So, as far as cancer is concerned in the state of Meghalaya, the first thing is that there is a lack of that trust, I would say, in the system. That's why actually still people go for, as Dr. Indra is saying, going to the traditional healers. But I'll just give one small instance. When we were having a district level awareness program, invited a lot of community members and also district functionaries. We asked one question: how many of them are actually, when they are sick, when they have a problem, how many of them are actually going to traditional healers? Almost like 2/3 of them actually raise their hands. So the thing is that it's something that, because Meghalaya is a state of indigenous population, there's a lot of trust on traditional healers. So the first point of why actually they're not able to do it, because still I think we have not set up the systems that would actually attract or really motivate the people to come and seek healthcare at the primary health facility, or so that's why the new mission is going to break that barrier of whatever that the trust barrier, or information asymmetry barrier. So that's I see
Most important
thing.
Tell me one thing, sir, to others also. So do you think this is a design issue, or a finance issue, or a workforce issue?
Yeah, it's I would say it's essential. If you look at it, it's a design issue, and also the way we also build the organizational culture within the state. So we need to really change that organizational culture. We need to be, this is something that I wanted to share with all of you. We have started one interesting thing just to build this institutional trust between the people and the state systems. So what we are doing, we are asking these multi-sectoral teams, not like only health teams, health, WCD, rural development. We are sending them every week to one of the villages. Every week, it's a weekly visit. They go to one village. They go and identify. They ask the community which are the most vulnerable households. They go and sit with them and listen to their problems.
what we understood is that, in fact, in my visits, which I do regularly, almost like on a weekly basis, we saw is that a lot of people are now, we are finding with a lot of early development delays. A lot of challenges we are seeing, and so there is a need for, then when you go, when you sit with then actually, instead of actually saying that they are not coming, we should go and reach out to them. So we need a completely fundamentally the organizational change that is required, the way actually we work.
Thank you, sir.
If I may supplement,
Yes,
Dr.
yes.
Joram here.
Yes.
In fact, the answer to your question would be between design and the other one you said what?
Workforce or
Workforce,
funding?
yeah.
Finance.
It's actually beyond that. I would say it's more of cultural. There is a deep, I would say, a lacuna on part of our people on the health-seeking behavior. Now you see, you must have heard Angelina Jolie. She has sort of popularized this. When celebrities do it, it becomes more popular. When it was detected that she had the BRCA1/2 gene, she went for mastectomy immediately, so as to prevent a future breast cancer and even uterine cancer. So in Western countries, people are very proactive. The moment they do a genetic profile, they go for something well in advance. But out here, as one of the survivor gentlemen also mentioned, initially whatever happened to him, he was reluctant, as Chief Secretary said, on a denial mode, and then when he sought the help of a doctor, now this is where the systemic problem comes. He met a specialist, but amongst us doctors also we have that sort of an unwritten principle that most dangerous diseases are rare, statistically. So mostly they will write it off as a common cold or a sore throat or a tonsillitis or so on and so forth. So even our doctors, had that gentleman met Dr. Anisha or any oncologist, the treatment would have started at least a month or two advance. So that is also that's a systemic problem. And when you also mention about equitable treatment, by and large for Meghalaya, as you rightly mentioned, in the population is very less. In Meghalaya, so far as access to treatment is concerned, it's a very egalitarian society. Nobody has to make a phone call to get a treatment. And Dr. Anisha will vouch for it. She and her team equally treats everybody, immaterial of whosoever that person is. So access to healthcare is very equitable. But on the two fronts that I mentioned, I think, in my opinion, that is one of the.
Thank you. Just to quickly summarize. Yes, please.
From my experience, I feel that the fear of the stigma of cancer is prevalent not only among the lay person, but even I lost two of my senior doctor colleagues to that. One of them is about 12 years back. She was my partner in the casualty department. The day she was to get admitted in the hospital, she told me that I am taking leave for private reasons. I didn't even know that she was suffering, sir. She hid it from me. And only when one of our colleague doctors, she got treatment in the private hospital, and one of our colleague doctors, she happened to visit that hospital and met one of our retired nurses who, after retirement, went to work in that private hospital. And that nurse told her that, one of your colleagues is admitted here for surgery. So I came to know from that, she didn't even tell me I'm going for treatment. And I'm sorry to see that she refused further treatment also. We had that VR that Sir had shown today. I think it would have helped her because she was mentally she was suffering after that surgery. And we lost her, I think, only for a few months. After a few months, we lost her. She was my partner. And another one is another senior colleague of mine. She was in denial. In fact, one of our senior specialists had advised her. She got this one brain tumor, but she was in denial, sir. She didn't want to accept that. The senior specialist had advised her to go for MRI, but she refused, sir. So that barrier is still there, even among the health fraternity also, sir.
Thank you. So what comes out is there is late diagnosis, because of fear, because of stigma, because of weak referral, because of reluctance to accept, because people seek alternate treatment, and that there is lack of trust in the system, and there are cultural issues that are deeply rooted in the community. Then I think we accept that this is a design issue, this is a systems issue which requires reworking our organizational culture. And an example was, multi-sectoral teams visiting individual homes to try and see how we can communicate better with the community. So having summarized that, I want to understand, for this state, for Meghalaya, given all these complexities, what is it? Each of you represents a very important vertical of the government, and there is some hierarchy, but each of you is important. But patients don't see each vertical. Patients see the ultimate, what is delivered by all of you together, or all of us. I as a doctor, all of us together is what the patient sees. And so I want to understand that what is the single most important lever that you possess in your position in the government system. So my question is, next slide please. Oh, it's not, I'm not able to use it. Anyway, it's okay. What is the single biggest system bottleneck preventing timely and equitable? Okay. So, no. Oh, next slide, please. Oh, slide. Yeah. Okay. Next slide. Yeah. So this is my question. Given your role, what is the single most important lever that you control that could shift cancer care from episodic to system driven? Next slide, please. Yes, Principal Secretary, sir. We start with you.
So, I think you must have seen what we are trying to do. So, as in the current role, what we have been doing is that we are basically mobilizing the entire state to prioritize health. So that's why the state brought the first of its kind health policy in 2021, and we brought this dedicated mission, cancer mission, so that we could be able to spend more resources. In fact, our state is the only state in the country which in fact our Chief Minister has mentioned in his speech. Today we are spending almost close to 9% of the state budgets on healthcare. So it is not that there is an intent, there is a strong intent that we really wanted to address this problem. For that, what is required is that required mobilizing those necessary resources, and also the people. We also require a very committed people to implement this. You can mobilize resources, but if you don't have committed people, you can't actually get results. That's why one of the things that what we have been focusing is that how to bring public service motivation among every functionary in the state. How people can actually work with greater sense of purpose. That's one example. I said multi-sectoral teams go into the field. When they see the poor, sit with them, listen to their problems, you get empathy. So the empathy actually again drives to really solve the problems. So that's a kind of a organizational change that we are trying to bring in here. So that's our focus as a if you ask me, that's what actually we have been trying to do. That we have been seeing a very good results in terms of, as mentioned by our health minister also, that we're able to see we got a lot of confidence that we were able to see the reduction in the MMR, AMR significantly. We also see here, especially in the cancer, we took the real issue. Real issue is not only the treatment actually here for us. As you said, the numbers, we can actually handle it. Real issue is that bringing that awareness and how actually we can, a mother, I will tell you the cervical cancer, in an opportunistic screening, Dr. Anisha found almost 10% of the mothers whom she screened have HPV. 10% of opportunistic screening. But if you look at the screening is very less as NFHS. So we wanted to really, that's why we wanted to go for self-testing kits for cervical cancer screening. So, and how can we, detect HPV. So HPV turns into the cancer. So we are trying to use the science. Another important thing what we are trying to do, this is because Professor Kannan, that's why we invited you and all experts. We wanted to use the research. There is a concept called research utilization. If we don't use the research, I think we are actually wasting, or in fact we are if you use research properly, we can save a lot of lives. In fact, that's another thing that we are trying to do. As I'm also the chair of the Indian Institute of Public Health Shillong, so in that capacity also some of the research work that actually we have been commissioning. Thank you.
Thank you, sir. So policy, you mentioned policy, you mentioned research, but what I'm most taken up is how can you bring a culture of public sector work in every employee of the government. That is something, even as a small organization, I have to take home. Thank you very much for that. The thing about HPV also, 10%, roughly across the country, everywhere the percentage of HPV positive women is about the same, 6, 7, 10%. But the good thing is, we don't have to screen 100 women. We only have to look at 10 women, because without HPV, we cannot get cervical cancer. So only people who are HPV positive need to be followed up for cervical cancer. It reduces the number of women who have to be brought to a hospital, put in lithotomy, examination, because cervical cancer screening, of all the cancer screening procedures, cervical cancer screening takes the maximum amount of time and faces the maximum amount of reluctance as well. And so, thank you very much. So, Commissioner Health, question is, next slide please. Yeah. So, looking at it from finance, purchase, contract, what financial or administrative lever could reduce diagnostic and treatment delays? Just taking over from what the PSL said.
Right. I would say, there is a very interesting independence speech by Jawaharlal Nehru. This is on 15 August 1947. He said, "At the stroke of the midnight hour, when the world sleeps, India will awake to life and freedom." For me as a bureaucrat, at the stroke of a pen, I can get all this thing done. So I will always ensure and do justice to the role and responsibility that has been given to me, to ensure that whatever the field workers are saying, requesting, should be made available to them all the time. We are bureaucrats, we are not experts. We should listen to the experts and not try to create our own theories and hypotheses. So this is what has always been a guiding principle for me. So I will also say, a bit of what Principal Secretary Sir said. The three most important thing for us is to mobilize, motivate, and mentor. And it's also part of the question that you asked me. Mentorship is very important. Today, Anisha and her team couldn't have achieved what we have achieved today unless we had mentored. It's very important. In government, it's like an ocean. There are thousands of people working under us. It's very important for leadership roles like us to identify people who are really motivated. It's not just like another job, but who are really passionate about it. So I hope I've answered.
Thank you. Just to add one more question of the financing chain, you said clinicians have to be helped. What part of the financial system is most opaque for Anisha?
Again, coming back to Meghalaya being very unique. Had this been UP or Punjab, Anisha would have not even gotten access to the secretariat. It's very difficult. But no, I work in Punjab, so I know it's very difficult. You need to have a card, and for the permission, you go to Government of India ministries. Without that yellow card, you don't get the access. Or somebody has to call from above, some joint secretary or somebody has to call, and then only you get an access. For Meghalaya, again I said, we are very egalitarian. The culture is our greatest strength. We are very egalitarian. It's not vertical. You said we are vertical. We are not vertical. We are very horizontal. Everybody is accessible to everybody. So that way, the question that you asked may be applicable for Assam and maybe other states, but not for Meghalaya. We are very
egalitarian. Talking of Meghalaya right now. Let's not talk of Punjab.
So Meghalaya, there is nothing opaque. She can come and see the file. Actually, she moves the file.
Okay, let me rephrase the question, sir. Is there somewhere financing unintentional, it is not intentional, I accept. But unintentionally, can you think of a situation where it slows down the process?
The point, your question is that yes, there are unintentional delays happen. That's a truth. So the reason is that because it's very difficult, that's why we also need to change the systems again. It cannot be individual based. It's not that like, today, we are here, so we are actually proactively doing it. We need to change the systems. I like this question, like it's not individual based, it's based on system change. We found, actually this again, all of you should be aware, there is one example I'll give you. To save mothers, especially for the maternal deaths, the biggest policy what we did was we decentralized the decision making to the MO level, medical officer level. So earlier, every expenditure has to be done from very centrally. So what happened, the moment actually the autonomy was given to the health facilities, how to spend the money. For example, from North Garo Hills, they were started using the same money to send the pregnant women for ANC checkups to Assam, because that autonomy was given to them. For them, it is solving the problem, not implementing the program. Earlier, no, you have to send them to Tura. Like you understand my point, but it's closer to Assam. So such kind of flexibility is important. That's why we have come out with a concept called outcome-based budgeting. So where we are actually going to give upfront, the funds well in advance to the health facilities. You understand, like, so health facilities. So there are certain, and there are other systems like, procurement, streamlining the procurement of medicines, and also that, like, there is a more, and we have a lot of systems that we have brought in. Similarly, like as you said, getting the, we also state also has given a lot of autonomy now to hire people on a contractual basis. Okay, don't wait for the sanctioned positions, but hire on a contractual basis. So a lot of systems needs to be improved so that, like, this requires a lot of thought process.
Thank you very much, sir. Thank you for that transparency, because the government is like a rath, to push the government. There are so many checks and balances. You have to get quotations, you have to get tenders, you get the lowest cost, you have to justify higher, and so it is a. So moving on, Dr. Sandra. Next slide, please. Next question. So, question is, what system capability is missing that training or implementation could realistically fit?
Right. Thank you very much, Dr. Ravi. In fact, all the questions that you started with and asking, as an institution, I think our job is to do the evaluations and the research that's required. And I'm happy to say that several of our publications is available. The research findings is available, including one which just got published in the Indian Journal of Medical Research just 2 days ago, and is available as open access documents. Many of the words that you heard today in the inaugural session, and even as we were speaking, from notions of stigma, because when I started off, when ICMR asked me to do the first study, I said I need to get an idea of what the situational context is, because they wanted us to jump in with an intervention, and I said we don't even know what's going on in our rural areas. How do you design an intervention? And so some of the things like stigma, we know stigma with HIV and lots of other diseases. Didn't really know that this much, and the extent and the manner in which it is relevant to cancers. So all of that is being done, and there are two quite important papers, I think, available, both from the systems level. We have identified several things in which, including things like training, and I think from a systems perspective, I could just summarize it as, for health services, I think what we really need, and a lot of you heard lots of important words from the Principal Secretary and the Commission Secretary, but I think what our directive should be to provide the services in a consistent and competent manner, in a respectful manner. And if you fail to do that, we have islands of excellence. That is not what we're talking about. But it's about consistency and clarity and delivery everywhere. More than the parameters, more than 80% of the so that 20% we can keep taking care of. Then if you look at the community, and unfortunately, or whatever, in cancer, ultimately for cancer care, we want to prevent, right? And a heart of it is in the behaviors. Now, any one of you who knows a smoker knows that behaviors are the most challenging. But try giving up tea. It's almost impossible, right, for all of us in the Northeast. So behaviors are extremely difficult to overcome. And we have a terrible behavior in our state, in our region, which is smoking, whether it is smokeless or smoking related. This is the heart of over 70 to 80% of our cancers. The cervical cancer is the exception. But all the others, this is what it is. So we, from doing our situation analysis and finding the research of what is going on at systems level and at the community level, we then said, now we can't just sit with research. We've got to find what will work. Because after all, we had an anti-smoking program and a breast cancer screening program for decades. And what's been happening? And so we are in the process. And so when you say what's needed, is to also find the solutions. And so we are in the process of actually doing a quasi-experimental study funded by ICMR. We said, we kind of notionally decided we're not going to lecture and preach to the community, pointless. So we will work with them to figure out what the solutions are. And so that study is going on, and we hope to be bringing up some of the results. Some early findings have told us. For instance, the women in the self-help groups, that was one group we definitely worked with. They said, forget all our older men in the community. They're never going to give up their smoking. But we want you to pay attention to our children. Because this state, our starting age of smoking is very, very young, too young. You will see children, and there's another study in which we also looked at the provision, the easy access to smoking and its substitutes, very near schools. So all of these are things that at the systems level, I mean, we've got great policies, we've got some implementation, but every step needs some monitoring and follow through to make that better. And I think our children are, it's very encouraging to us to see in this intervention that we are trying, how they have come, because they're concerned about their fathers, their uncles, their grandparents, and want to see them live full and long lives. And they have been coming up with saying, no, this is what we could do, this is what we will do, and so on and so forth.
So what capacity gap could you help plug in the next 2 years?
I think in terms of identifying approaches to interacting with the community in a participatory manner and finding solutions, that's one. And I think in the other side is if the state requires, we have several people in the machinery already, looking at how can we deliver the strategies, especially in terms of communication, in a consistent and context-relevant manner. So those are all.
Thank you. Director of Health Services. Next please. Oh, I said, so question is, what data are we not utilizing today that could help guide decisions? We have registry data, we have hospital data, but what is the data that we are not using?
So we have the data from the screening results from the screening at the PC, CECs and the CAMs. Then we have referral and follow-up status of the suspected cases, the time taken and from the screening to diagnosis and treatment, and also the dropouts and the patient that were lost to the system, and also district-wise case trend. But these data we have not been using them, and we have not analyzed and reviewed these regularly at the district or the state level. If we had done that, they could have guided us a decision on with regards to resource allocation or with regards to supportive supervision, referral strengthening and targeted capacity building. So these data we have not been using regularly, sir.
Thank you. But tell me, ma'am, you've not been able to use it because of staff inadequacy, or the referral pathways, you identify and then you're not able to effectively refer, and so the data is unutilized, or what diagnostics or follow-up, what is it that prevents?
I'll just supplement what
Yes,
she
sir.
said.
Yes, sir.
There's one more issue, I think it's very pertinent to your question, and which Principal Secretary mentioned in his inaugural speech. We don't have a PBCR in registry in Garwins. That's a huge region of 6.
I thought they are starting one.
No, not as good. So Anisha has been flagging this for the last 3 years. and since you have good contacts in ICMR, will jointly take it up. So significant, so numbers that you are seeing, whether it's in Lok Sabha or in our presentation, they're actually on the lower side.
It will be. It will be.
So we don't know the numbers, and that's number one. And number two, because of the healthcare facilities we have, a significant numbers are referred outside. Maybe coming to you also, your hospital. So God knows whether they are registered with us.
No, that is registered across the country.
Okay.
In any hospital it appears, it comes into the PVCR and that will be sent to the civil hospital registry.
Okay. So a significant numbers are going to the private hospitals also. Like CMC level, I'm sure, good number, Tata Memorial also. After the war, there must be full of people from either Meghalaya and my home state, Arunachal. So I don't know whether those numbers are also there. So I think that's one, yeah.
Yeah. So all of it is linked.
To tell everyone, this data I think I have not shown in the morning because it's inaugural session, I don't want to take long. There is one first cancer project that we have done here in Meghalaya. I think you might be aware, it's with World Economic Forum, and we started with State Cancer Society, we did this. The idea was to screen everyone above 30 years in East Khasi Hills. So this was done. As part of that, about 1 lakh people have been screened in East Khasi Hills in 1 year span. Out of 1 lakh, then they said because the risk, basically asking questions whether you smoke, whether lot of risk people were about 48,000 they have identified. And then out of them, only the agreed for visiting health facility about 9,896. 48,000 only agreed for. That means so much dropout. So last, because basically we must understand. That's why I said initially a lot of trust and confidence, a lot of is required. Then whoever is agreed visited only 2006. So basically, what we are missing is that we have this data. But again, if I ask again our own state cancer society, our district, entire cancer mission, have we actually, gone and followed up with this 9,000 people who have agreed? No. So a lot of work is required to be done. This is so definitely a lot of work is required to be done. So there is a data, but what we are collecting the data, but we are not using the data. That is the problem that what we have. Second is that I also said this one. For example, the cancer, there is an interconnectedness between the data. One data shows that another data that what we have, not only the NFHS5, recently we have done another study to understand the early childhood development related issues. So we found, in fact, a large number of mothers are not actually practicing exclusive breastfeeding. Exclusive breastfeeding means first 6 months only breastfeeding should be given, nothing else should be given to the children. And early weaning is happening. So if you look at it again, breastfeeding also helps actually reduction of breast cancer related issues. Maybe we have to really promote based on the data. Actually everything is interconnected. So maybe a lot of these things, and we also have multi-gravida. If you look at a lot of maternal deaths what we have had, multi-gravida. And again, multi-gravida has a relation with, again, cervical cancer related issues. So a lot of data, I think a lot of, intelligently we have to look at it and connect the data, and a lot of collaborative work is required.
Thank you, sir. Thank you very much. Just to add to what you mentioned about the first cancer project, so we screened, geographically screened 50,000 people in one health block, and we found about 40 cancers and about 83 cancers, but more than 95% complied with the project because the ASHA did this triage examination at the home, but a lot of labor. So quickly we changed to using the CBAC form. Again, another 45,000 people in another health block. The CBAC form was administered, and those who had high risk features on the CBAC form, so out of 45,000 people, about 4,500 people needed to be seen further. Yeah. No. Oh, okay. Okay. No, can we go back, please? I missed one question. Can we go back? Go back. Yeah. Director of Health Services, I had a question. At the level of service delivery, what is the single operational lever that you control that could make cancer care more reliable? Not just so. What is it that we can do? PSR said not to decentralize. What is the single most important thing that we could do to make cancer control more realistic?
So we need to standardize and enforce district cancer pathway in that should be anchored in primary care because there could be misdiagnosis and under recognition as many of us has mentioned in primary care. Suppose a patient have symptoms like bleeding on touch. It can be anywhere in skin or mouth or anywhere, then we can suspect that it may be cancer. So we can flag the symptom checklist at primary care level so that they can recognize what are those symptoms, what do we need to refer. There should be clear referral guidelines or SOP, whom to refer, where to refer, and how fast it should be referred. And then maybe we should need map pathways of the district diagnostics where it is available and treatment centers also. Then we need to have a referral completion tracking system and also two-way feedback to referral facilities. Sometimes we refer patients from from sub-centers or PHCs to a higher level, but then there is no feedback. Once we refer, we lost to follow up. So there is no continuum of care.
So where do you think the biggest crack exists? Where do most of the patients fall through?
It's a failure to follow up.
Yeah. So what we found is when we refer them to a sub-center, most of them will go. When we ask them to, about 90% will go. When we ask them to go to a PHC, about 65-70% will go. When we ask them to go to a medical college or a cancer hospital, only 25 to 30% will go. That is what we found. I don't know if that is the same story here. Thank you, ma'am. The Director of Medical Ed, next please. Okay. So because the Director of Medical Education is not there, there are two questions that you have to take care of. Keep it there. Next one also. So what change in training or postings could strengthen cancer capacity outside of tertiary cancer centers? And then second part is how can the medical college anchor district level cancer care rather than ask everybody to come to the medical college? There is Nigrims and now there will be Shillong Medical College, but both are in Shillong, and probably you'll have a cancer center college in Tura, but then they will still be in big cities. What happens for somebody in Umkyang or Ladurbai?
Thank you very much, sir. Regarding the workforce pipeline, I'm still very new with the directorate, and actually the Director of Medical Education would have been a more befitting person to answer this. But as a doctor, I feel that this training should be right from the grassroots level, like you say, the ASHA system and all that. And the postings could go like, you could have a rotational posting of doctors, dedicated doctors, around the, say, each and every district. And maybe in this way we could have a better chance at screening, and then the overall, better diagnosis of common cancers. And say, like these days we say that the PHCs and the CHCs, they should be the ones who should start, say, at least chemotherapy, if not radiotherapy, because let me combine these two questions, because actually there is you have, let us say that the district hospitals are usually the first interventional center, so to say, and the medical colleges usually come as the tertiary care centers. So between the two, the district level, they are usually the default site of care. and they should be the ones who should be doing the screening and the diagnosis, chemotherapy, chemotherapy, palliative therapy, and also follow-up. Whereas the medical college, usually in this day and age, what they do is teleconsultations. They do complex diagnosis of maybe diseases which are like, you have the, what we call them, you have cancers like head and neck cancers. We have there are times when the patient is in a stage of dilemma as to whether it is just a simple sore throat or it could be in a cancer like stage 1 CA. So, and then radiotherapy. Radiotherapy usually, I think, it is only in specialized centers that you can have, like a medical college. So, and then, so my take on this is that the Shillong Medical College, or any medical college, should be like a clinical gatekeeper, not a kind of a sponge where all patients are referred there. A referral center, the patient goes to a referral center first, and then comes to the medical college for a second opinion or maybe something like that. And as you rightly said, when they reach the medical college, when you say you have cancer, most patients run away. They don't want to come back. They either say that, oh, we need to go to a better doctor, or we need to go to a better center if they have cancer. Maybe going to the civil hospital is not good enough. We need to go somewhere else. There may be a lot of different opinions. So that is also another thing. So we have to build this kind of a trust between the patients, in the district level, so that they and the caretakers at the district level should be able to convince them that they need further treatment.
Thank you.
Dr. Karan, if I may just add
Yes,
supplement.
yes, sir.
So, Principal Secretary and me, we always joke, some of the best ideas comes up when we are walking on the corridors. So today also over tea, we just discussed with Dr. Chinna Babu from Grace that why don't we send our doctors for a certificate course on medical oncology. So in future, maybe once our capacity is built, Shillong Medical College is very new. In future, we can come up with teaching modules in which doctors at the level of, say, district level can be trained, so that, what the gentleman, the cancer survivor was mentioning, that when he came with the thing, the medicine specialist prescribes something else. So that kind of thing can be prevented.
Thank you. I have something for Dr. Chinnababu later. Joint Director of Health Services. Next slide. Next question, please. The question is, within the NCD program, what lever could be used to bring cancer care earlier, closer to primary care and earlier in the patient's disease journey? See, ultimately, diabetes, hypertension, stroke, cardiac, all of them cancers, all of them have shared etiology. And very often, a patient with cancer will also have had a stroke or would have a cardiac disease. And could be the other way around, somebody so it is known, well known, that people with obesity or people with diabetes are at higher risk for certain cancers. They share similar etiology. So how is it, what can within the NCD program be done? What is it that you, as the director of the NCD program, can influence?
Thank you, sir, for the question. Actually, a few days back, we had a meeting with the Principal Secretary, Sir Sampath, and we're very grateful to him because he is taking NCD in the top priority now. So what we've decided is we will shout the first thing, because we are targeting screening. So the first thing that we'll do is we will shout awareness. We have our awareness in IDC and hoardings and all, but no one looks at them. So we will shout. We will use social media and another thing that Sir Sampath had suggested is using the traditional healers and also the community members, and we also have the community members here. So we've had a talk with them, and we will really move forward with that. And but actually, I also have a question for you. From our program, what we've seen is because we're moving to screening, and screening is happening at the subcenter level. That is the population-based screening, which is being done by the CHOs. Now, the problem with us is we don't have cases where we can do hands-on training for the CHOs. Sir, do you have any suggestion for that? Like to build up the capacity of our CHOs?
So Project Echo, a lot of this is already happening. I will talk to you after this panel is over. But there are many things that we can do to facilitate this training and accelerate it.
Thank you, sir.
So my question is, how much? So we know from the family health survey that the penetration of screening is actually very small. So, but have you looked at what is happening to the CBAC forms? How many of them are filled up? How many of them are filled up with good fidelity? Does it match what is in the computer and what is in the paper and what is reported? Have you looked at that in greater detail?
Yes, sir. We've looked into that also because during the CRM visit, we've visited facilities, and what we've seen is in the CPAC form, there's just a long line and no. So that is what we found out, and there were many instances where when we talked to the ASHAs, they say that when we visit people's home, that happens mostly in the urban areas. Like as soon as they see the ASHA, they close the door. Yeah. So that is another issue that it becomes difficult, and most of them always tell us that when we go to people's house, they say, why do you want to be so inquisitive, wanting to know whether we smoke or we... So those are the issues that we really have to build up the capacity of the ASHAs also in creating certain helping them in reaching out to the people. That is what.
So what is it that you can do to change this? How will you see? I thought the Asha hailed from that community, from that tribe, from that village. So if they are unwelcome, what is it that we can do to make them more welcome?
This is something there is a as you said. In fact, even we were actually, I was just sharing with my commission secretary. So we were going for one household visit as part of our human development leadership program weekly that we do, and we were our Asha was taking us to one households where the uptake of these services are very low. So she wanted that we should go and actually talk to them and motivate them. And in between, on the road, the male folk, they stopped the Asha. Why are you taking the team there? So, but I like Asha. Asha just brushed him just like that and she went. So that's why my respect to Asha's is immense. Despite all that, they are doing extremely inspiring work. But what I wanted to say is she's alone now. And Asha has been seen, slowly what happened in the system, Asha has been seen as representing the health department than the community. We need to change this. Actually, Asha has to represent more community. So how that can happen is that's why we came up with this idea of village health councils. So now in the villages village health councils have come up. So they are taking the health as a responsibility. In fact, some of the villages, the headman has taken such a seriousness, and they go to village house to house, and they actually, amazing work headmen are doing actually in some of the villages. So, of course, out of this 7,000 villages we have, active village health councils are only 1,700 so far. So we need to really make all the villages.
How did you get the headman?
We have this village health council application. So where we also have the monthly minutes of the meeting. They take a picture and send it through the app. But of course our MOs have to review that one. They are not yet started that one. There are 1 lakh records are there. 1 lakh meetings have taken place in the last 2 years and so. So that means so many meetings are taking place. But that's what I want to say. A lot of active that there is a systemic point to ensure this kind of a participation.
Thank you, sir. Dr. Chinababu, I know this is a surprise on you, and I don't know how long you have been here associated with the health services in Meghalaya. But my question is, how can a private organization influence the course of cancer care in now we're talking of Meghalaya, so in Meghalaya?
Okay, thank you so much, Dr. Ravi Kannan. It's always fascinating to watch your work, and you have influenced my work too, without unintentionally, if I may say. Coming back to the role of private sector, in general, you see, not in this part of the world, but in South, if you see, majority of the cancer care is delivered by the private sectors, and if you look at the because it's a capital intensive care that we're giving in cancer. So given that, I strongly feel that the big role for private sectors may be training, capacity building, or for that matter, even investment for radiotherapy, because you are mentioning today, there are about 6,000 patients per year here, new cases. So of which probably 50% would require radiotherapy. So 3,000 patients would require radiotherapy, for which you might require at least 6 to 7 linacs, because one linac can treat about 400 to 450 patients a year. So given that, I think this kind of a quick kind of a delivery can happen with the involvement of private players. Maybe not just private in that sense. Could it be something like the hospital where you are working not for profit, and sustainable kind of a social enterprises can come in, so that you can actually provide better care and access to these people. This is similar thing I have done in a community center near Hyderabad called Nizamabad, wherein for the past 18 years I've been going every Friday and built a system. It's self-sustainable, even though you have to invest money, but you can make it really self-sustainable.
And that's the question I wanted to ask. In the South, a majority of private sector, not majority, an overwhelming majority is for profit. And for that reason, there are several questions raised. I'm not going into rights and wrongs and ethics and all of that, but the fact is there are several questions raised about the motives of the for-profit sector. So now in that context, how do you reconcile the for-profit sector as a social enterprise? How do you make a for-profit sector focus on the social profits over the economic profits?
No, I think, see, your question is very valid, because the minute you're talking about these private hospitals, the commercial angle comes in, and people might afford.
I'm not being critical at all.
That's a fact too. So, I think social impact is the most important thing. For me, I strongly believe that the return on investment need not be financially, it can be social return on investment also. So I think with that intent, people can come forward and set up such facilities to provide the care.
So how do you influence that? How do you guide the for-profit sector into getting interested in a social enterprise?
No, honestly speaking, cancer care today, even if you are doing a social angle, if you go also, it is still sustainable, profitable. Because the government schemes are available, so you are actually not treating anybody free of cost. For the end user, it is free of cost, but the government is paying for that cost. So in that sense, it is sustainable. It is not really, kind of burden.
No, I agree that it is not unsustainable. Because with the changing milieu, the emphasis on CSR, with the government-supported health insurance schemes, it is sustainable. But what you define as a margin for sustenance is what I am asking.
Honestly, I don't have a clue.
Thank you very much.
Thank you so much. Business part, I do not know.
I won't get into that. So let's go on to the last part of the conversation. So when patients experience care, they don't experience different programs. No, they experience the sum of everything. And so I think from all that we discussed, one of the biggest problems is the process of handover from a symptomatic patient on CBAC handed over to a sub-center, from a sub-center handed over to a PSC, from PSC to a district hospital, sometimes from a district hospital to the medical college or to Neegwings or to the civil hospital. And so this handing over, and every handover there is a dramatic drop, there is a loss, So my question is, Can we have the next slide, please? So, question is, what one integration between primary care, district hospitals, medical and or program that consistently breaks down? I asked this, alluded to this a little while ago, but again I want to ask, which is the biggest bridge that collapses amongst all of this? Sorry? From which level? From primary care to district hospital to medical college, or the whole program is skewed?
From cancer perspective or from all?
So here we are talking of cancer, so let's stick to cancer. But it applies to heart disease also, it applies to stroke also. They run parallel.
Definitely. But just like I wanted to say that looking at your integration, where we are missing. We are actually, as I said, like, there is a, I'll just give an example, I think, to another, that actually we can take it here also, just give an example between, exclusive breastfeeding versus, breast cancer, or breastfeeding practices versus breast cancer. So some of this interconnectedness of things is missing in our system. For example, are we actually CPHC program, what we have, comprehensive primary healthcare program, how actually are we actually meeting, the required number of, so basically I think the data is actually something that we are not analyzing it, and we require, I think we need to leverage that, the recent digital, innovations, whatever that is there on data analysis. I think if you have that, because humanly this is very difficult to really appreciate the data and take decisions. I feel that's where the missing part, especially in terms of early detection. So we really require a life course data. Suppose for every person, like now that we are getting this health ID, like ABHA ID, you heard of this one, every person's data should be there available, and the data should be able to tell us, what is the early signs, who needs to be, screened early. I think some of these things we are missing, and also we also don't have, if you ask me, we have universal health coverage is there, as I said, but we have the mostly for the treatment, not many for the preventive prevention. So I feel the preventive part, we are actually detecting only when the problem arises. Can we actually detect before the problem sets in? I think that for that we require a lot of good information systems or data systems. I think that's a key thing.
So tobacco, alcohol, dietary preferences and practices, physical activity, some infections and inflammations. Just 4 or 5 causes account for cancer, heart disease, stroke, diabetes, hypertension, peripheral vascular disease, whole lot of pregnancy, so many, cataract, so many diseases, same set of etiological factors. So how do we create a comprehensive prevention package that looks at the disease agnostic? Because they cause all these diseases. So where is it that we are lacking there, sir?
No, I think this is not necessarily from the medical fraternity or from the system, the governance itself. It has to come from the public also. It's like both are equal partners here. All are stakeholders here.
Yes, sir, you were going to say something.
Yeah. So again, coming back to your first question first, one I said, both of us said it's the referral. In particular for cancer, it's also the follow-up that we have reiterated again and again. As you heard from many of the panelists here, even after the first detection, people actually prefer to go to the local healers, traditional healers, and when the lesion has fungated, the lymph nodes and all, then they come. So mostly if you go to cancer hospital, our cancer hospital also, many of the people have come in advanced stage. So follow-up, I think, is one of the biggest issue. Now coming to the next question, immediately improve the cancer. Now, not just for cancer, for other diseases also, we are coming up with a Meghalaya Medical Services Coordination Center. So it will be call center, wherein both there will be coordination between the healthcare system and also triaging. If any individual citizen calls the call center and says, these are my issues, so there will be a team leader as a doctor who will triage it and will take a decision at what level it should be referred when, where and to whom. And the coordination center will have contact number right from the ambulance driver to the DMHO and both our numbers also. So that matters will be escalated as per the level of and the seriousness of the issue.
See, the MMR and the IMR came down, the ASHA came, and then there was incentivization for institutional delivery, there was incentivization for initial vaccination. So do you think something like that could help the cause of NCDs as well? Do you think if a ASHA brings an early cancer, she could be given 10 rupees, brings an advanced cancer, she could be given 5 rupees, brings a palliative care patient could be given, can something like that?
It's like these incentives, as I said, incentives actually go to some extent. I don't think we need to understand more systemic issues. I think that's where I think the change would come up. So for example, maybe we need to, and for NCDs definitely we require a different kind of an approach. We cannot actually burden ASHA on this particular aspect a lot. It's of course there is I think we require a more whole society approach. That whole society approach would come up like active involvement of this entire village health councils and where the community members are, including the faith institutions. In our state we have faith institutions, they play a very important role. A lot of like what we are talking about, whether it's a lifestyle practice or change that can happen only in the faith institutions and the traditional institutions come together and work. A lot of work is required, and that, for example, as I said, for our chief secretary mentioned a large number of people. In fact, almost like 50% of the when by the time they enter into the adulthood, they are smoking. So that itself is a serious cause of concern. So I would like to there's a whole of society approach is required. Incentives has a limitation. I'm not saying that when there is because even like in our maternal mortality reduction, the key thing was that like when we started working on the more of a systems level interventions, that actually has otherwise bringing change faster. So I think we need to.
Just because you mentioned incentives, they do work to an extent, but then sometimes we lose some social capital by incentivizing everything. And so I would have a small cautionary note on trying to incentivize everything. That's their job, right? Some of it. So maybe it's not the ASHA who should be doing some of these things. There are others like AMMs and others who can be. There are other volunteers who have the passion. Because when you're talking about behaviors, it has to go not
when
just.
When we say should, we lose the process story.
Exactly. And when you talk about integration and what is it that people are afraid? Like you said, you're right. As the healthcare center facility is further away and bigger, your dropout rates increase. One, they are very afraid of out-of-pocket expenditure. Though we have a universal health program, first of all, a lot of them don't know what that means. They know something is there and some amount will be covered, but they don't know what the extent is. The next thing is, you still have to go further away, you have to take somebody with you and go stay somewhere, right? And that they have heard through the network that this is expensive. So that's another hesitation. All of us, if you have to go to CMC, we are nervous, right? And however well off you are. So that is there in different levels at every household. And we see this happening in different ways, and it's not easy to deal with, but I guess we got to keep working at it to find solutions.
Thank you very much. Before we close, we have any questions from the audience? Vikas, Caleb, do you have any questions for the panelists? Anybody else? No. We have some very amazing people in the audience, So any comments, any questions? Alright, any final comments from the so just to conclude, just to put everything together, 3 or 4 priorities emerge today. There is talk of workforce capacity and distribution. There is a lot of emphasis on referral and navigation. There is a lot of work to be done on utilization of data and using that to fix accountability. And then there's some discussion on the financing and the funding models. None of these are about individual excellence. They are not about an institution or an individual or a department being, they are all of us together making good care dependable. The shift from individual care comes with accountability when systems start moving. And so that's where we are. Thank you very much. Thank you.
Outcome of the Hyderabad, the Telangana Northeast Connect program, which was launched by the Honorable Governor of Telangana, Sri Jishnudev Vermaji he is from Tripura. So as a follow-up of that, this has come in. So even as you see here, I think the biggest problem, if you see to the next slide please. Yeah, the biggest problem, I think this is one slide that I want everybody to look at. This is what I call as the 4-4-80 formula. There are 4 shared modifiable risk factors which account for 4 major non-communicable diseases, which results in 80% of the NCD death. I think all these 4 are modifiable shared risk factors, made with tobacco consumption, unhealthy diet, physical inactivity, harmful consumption of alcohol. Now they lead to either cancer, diabetes, cardiovascular diseases or pulmonary diseases, so which leads to 80% of the mortality. So given that, I think we need to prevent the preventable. This is in our hands. Can you go to the next slide please? Yeah, so this is the story of Mahesh, which made us to start Grace Cancer Foundation 13 years back, wherein a young family of 3, Mahesh succumbed to oral cancer at the age of 28, leaving behind 3 children. That's when the Global Research and Cancer Education non-profit came into existence. And if you see that, why have we come up? What are we doing it? Basically, the intention, the vision is very simple, and it's a very similar vision. How can we alleviate the cancer burden in the community? So for that, we achieve our vision through 4 pillars of our mission. So which includes education and awareness, early detection through mobile screening campaign, treatment and rehabilitation, and of course we focus a lot on the research as well. So these are the 4 verticals through which we reach the last mile. So if you look at the philosophy of Grace Cancer Foundation, so prevention first from healthcare is actually not healthcare, it's a sick care. So we want to move away from sick care to a prevention first kind of a care, which is community owned, and mobile cancer screening at the doorstep. Reaching the unreached at their doorstep is the philosophy with which we are working. Can we quickly slip I think these are the founders. The advisory board includes Dr. Nori Dattatreya, who was the Padma Bhushan awardee this year. This is a journey in the last 13 years, being able to scale the cancer awareness and also cancer early detection, including the treatment at the grassroots level. Next slide. So the 4 pillars, I'll quickly mention what we are doing and how we can replicate this model of the GCF way in Meghalaya. Next slide. So the awareness and education part, this is again, this is being debated, discussed today multiple times, include every sector, right from school students to college students to faith institutions. Everybody is part of this drive. So, webinars and in person, offline, online, and we also do a flagship event called as the Global Grace Cancer Run, which has been done for the last 8 editions across 130 plus countries. More than 300,000 people have participated last year itself. So the awareness drives happen. We also have Dr. Pramila, the co-founder of Grace Cancer Foundation here. Next slide. So the awareness drives include the students, also make them as the ambassadors for cancer awareness, give them a certification course, and a structured program is given to them, and they take this message to their parents and their neighbors in their villages. And since I'm a Navodaya student, we have been involving the Navodaya, the alumni across the country, which is a very strong network. Next slide. The Grace Cancer Run, you see the multitude of people, how they come. It's not just a run. Run is a culmination of the effort that we put almost 6 months, awareness drives happen consistently. And then, in the month of October, 2nd Sunday, people come together for this cause. So across the world, this, the awareness drive is happening at scale. Next slide. So the early detection is again very close to our heart, more than the run and the awareness part of the drives that we do. Mobile cancer screening at the doorstep. About 100,000 people is what we have screened last year. This is what we have standardized the steps of screening, what we call as the GCF way. So 8-step process, everything, even a regular healthcare worker can actually follow these steps and do the screening wherever they want to replicate this. We don't require highly skilled people. You can watch this video if possible. Can you play the video please? It just shows the GCF way, how the bus goes up to interior areas. Wherever there is a road, the bus can go. So this is how we standardized A-step process wherein we reach the unreached people wherever they are geographically, how much or far they can be, wherever there is a road or buses are able to go. In fact, today the buses drive us rather than we driving the buses. Go to the next slide. Keep skipping these slides for want of time. We had a privilege to screen both in Orissa, Chhattisgarh, West Bengal, multiple places. So at the doorstep for most common cancers, the screening is done. It includes mammography, HPV testing, pap smear is there, and we're able to reach out. Real-time analytics is possible. Anywhere you can be able to see the dashboard of how many people are screened and how many are positive, what are the outcomes, everything can be tracked real time. Next slide. So the research, we're looking at a couple of molecules for the colon cancer prevention. Basically, that's where we're looking at anti-inflammatory. We're using the aspirin as a repurposing of this drug for preventing colorectal cancer. So planning to launch very soon. A lot of progress is happening. Also looking at the targeting anti-aging because longevity is a big thing that's coming up these days. So looking at launching a molecule as well which targets the senescence of the cellular level. So the impact of model, thousands of cases are detected early. I think that's where it's more than the number of camps we have done, number of lives that we have saved through early detection is what gives us satisfaction. So if you look at this 1.6% the screen detected cancer rate, and in some areas 12 to 13% first time diabetes and hypertension has been diagnosed. So in that way we have been able to reach to more than 14 million lives, and through this the thousands of lives have been saved. Yeah, so across 130 plus countries, the reach has been there, but more so through these 6 mobile screening buses, we've been able to go to the nook and corner of this country, and it's a privilege that we are actually coming to Meghalaya as well. Next slide. Next slide. Of course, scalable models through records doesn't matter at the end of the day. Every life that we save is important. But we have done a scalable model for breast cancer screening, cervical screening, across multiple centers, and we're also using AI's oral cancer screening application, and of course the tele-oncology consultation possible through the platform that we have, and very good referral systems so that you don't lose out patient for follow-up. Next slide. So tobacco-related cancers is an important opportunity for us. I think that's what we can do here in Meghalaya, focusing on women's cancers, esophagus, the oral cancers, and we can actually make a real difference in detecting them early and saving lives. So the delivery model, I think we have discussed at length through the panel as well. I think the very good structure is available here thanks to the interest of the bureaucrats here. The system is very much in place, so we can definitely scale this up and screen the eligible population throughout the year. Next slide. So next slide. So prevention-driven healthcare is, I think, that is the buzzword that we have heard all through. And that's where I think the sustainable cancer control is possible. So go to the grassroots, replicate this model, the mobile and portable technology, take the standardized workflows and very strong referral linkages and AI augmented screening. I think aggressive measures to control tobacco, early detection through widespread screening, because we've been hearing less than 1% of the population is screened, which is really painful. So HPV vaccination and cervical cancer prevention, again, we have launched today. So mobile cancer screening for hard to reach areas is, I think that's where we can actually detect these cancers early and make a real difference. And of course, telemedicine, the Secretary of Health were mentioning today that we can actually work even for the teleconsultations for medical oncology services, which are not that much available at this point of time here. So preventive care at the last mile is the first line of defense. Early detection saves lives and reduces cost. We can prevent the preventable. We have seen the 4 modifiable risk factors leading to 4 NCDs causing 80% of the mortality. So we can bridge the care gap, access and affordability with technology integration, with AI coming in a big way. Together, GCF and Meghalaya can make a true difference. That's a real opportunity for us, and for which I am extremely grateful and honored to have this privilege to work with the government of Meghalaya. Thank you so much for your patient hearing. Should you have any questions, happy to take them.
We should train our people to a chemotherapy or surgery and send them to the village or the peripheral health worker. Now I wanted to ask that time whether it is feasible. You train, suppose that I want to give a chemotherapy. Now I tell any PHC doctor that you are trained for 3 months in chemotherapy, and I send the patient to chemotherapy to the PHC. Are you comfortable in giving or administering that chemotherapy? How many of you are comfortable in that? Do you feel that these short-term trainings are adequate to take about the care of the cancer at the village level or the PSC level?
Well, I think training to treat the patient, that is not that is totally not okay. But training people to diagnose, that is 100% yes. Otherwise, so if you train staff to give chemo just like you give and go home, there might be long-term side effect. There might be long-term consequence of that. So training the personnel to treat, I won't encourage, but training the personnel to early diagnose and proper referral, yes, that is doing it.
Anyone has a different saying?
Yes, sir.
Caleb is also there. Caleb, you have to say anything on this training and treating at a peripheral center?
I think primary health center will be too low for chemotherapy.
District hospital, yes.
District hospital, because you need to have at least a facility for doing a blood test and ability to detect febrile neutropenia, those things. So I think we should not go down to the primary health center. Primary health center should be treating only what they are intended for, I guess.
So the major issue, what we expect as an oncologist when you treat the patient in civil hospital or private hospital or negrimus, wherever we want to treat, and the patient goes back to the village. Suppose that we have given a chemotherapy, we will have neutropenia, so we will come with the pain. So what we want in the initial from the PSCs and CSCs, to at least do a test and see what the CBC counts are, what is exactly complaint. We are seeing the patient who are referred for changing of the rise tube also, which can be easily done at the CSC or PSC level. The rise tube can be easily done. But there is a tendency to just refer the patient. This is a cancer patient, you go to Shillong, or you go to wherever the treatment is started. So if that can be changed, it will make a big difference to the patient. Now what we started doing differently, like we also ask the patient when we send the patient home, mostly for the pain and terminally ill patient where he is on pain and palliative care, we tell the patient, is there any PSC or CSC nearby you? So if he says, yes, there is a PSC or CSC within half an hour, 1 hour distance, we tell him the relatives or the patient who can go. You go and tell the doctor there that I know the disease, you show us our discharge card, we write clearly there what can be done. The patient can show to the nearby doctor for the further test or changing of rise tube. And that builds up the trust. Now, there is one person who Valencia is or to the peripheral centers.
Aku abacia tu EP, akran benda khasi, aku por bi ba Gordon is dog joga ipam, rambut bakadai gastric, nama iklan hawan bam kuai, hadiah nanta ipha shapo, Bulan Hospital, balai ke endoscopy. Then after that, you should get shapo Guwahati for second opinion. Dah hadiah nang tu. Now, hari ini aku nang turun po gastric, galet ni Dr. Karung Nuat, dia explain bahahi, ya ke A ke BMI, hilang habok report. Dia nakabata juga kalau nanti siya ngaptip ya ke A ke BMI, imbatai balai you, isyong bay directly ba lendo siya po oncology. Hadiah nang to ida ikendu ya Dr. Anisha Maulong, she's a very good doctor. Yarap sisya better bensin ya Gordon Jerwa ba in 3DE. Kita ting kibrio kiba ong bali film dan yo shibidor. Ndray habangin don isa isanya may tanghau play. Pangkatla.
Yeah, so what we wanted is that the village health, whatever the PSC, CSC, they should also offer some basic care to change the right to give the painkiller, morphine distribution, which is the most important for the pain management. That should be done. So these are the various points which have been taken from various publications, like misconception about the cancer, hesitancy and perceived stigma, fear of cancer diagnosis and treatment, negligence and misinterpretation of the early symptoms, self-management and use of over-the-counter drugs, preference for the traditional medicines, financial constraint, misdiagnosis and health system related, like seeking opinion, even if you are diagnosed early, you want to take a second opinion. There are many patients who come to our hospital, they said, we don't believe in our biopsy which was done at the periphery, you do a second biopsy. Now sometimes these biopsies are easy when the growth is quite obvious, but sometimes lung biopsies, when biopsies are not so easy to do it again and again. So we have to tell the patient very properly and counsel them, no, it is not required once you are diagnosed, it is confirmed and you can go ahead with the treatment. So after the discussion, there are various issues including the financial barriers, physical accessibility, social and cultural barriers, organizational barriers are there including the skill manpower availability. We are only 20-25 oncologists all over the Meghalaya, so that itself is a lack of what you say, that trained manpower in the Meghalaya. We don't have a single nuclear medicine specialist, so we don't have a PET CT scan in our state. Slowly we are trying to get a PET CT scan in Nigrim slowly. We hope in the near future we get it. But we don't have nuclear medicine specialist in Meghalaya. High-end ISC test, we have to send our sample to outside to get some molecular high-end testing done, which is not available in Meghalaya as of now. Radiotherapy, although now it's available in 2 of the centers, and hopefully Tura Civil Hospital is also in the process to get a separate unit. Supportive staff, pain and palliative care services are not up to the reach of the peripheral villages. So in terms of availability, yes, it is not available equally. I think I'm short of time. Farida is showing me the template again and again. Any question from the audience, or any audience from the member from the audience who wants to put anything? What could be the way forward? Just a quick point, Dr. Jayanta can explain what could be the way forward and how we can strengthen. I think some of the points are already covered in the morning panel discussion.
I think it is the duty of basic right from the low level with sub-center workers right to the government to give some more financial incentive to the patient, incentive in the sense in the package treatment and all. And plus diagnosis also, early diagnosis. Being a northeast state where CA, esophagus and stomach is highest in the country, you can see it is a cancer capital. I think government can do more of diagnostic. Why not to introduce a screening center, endoscopic screening in all the district hospitals regularly. They can have an endoscopy fan and go to some rural areas and do endoscopy wherever there are patients, suspected patients.
At this point, last year also, in the last Meghalaya Cancer Conclave, 12 endoscopy sets were distributed to 12 districts of Meghalaya to do the endoscopy, which was available at a routine screening. But the response is not good from all the districts. Some districts have done really well. I don't know the data exactly, but yes, if that can be utilized, probably our screening rate and early diagnosis will definitely increase. So government has taken initiative to do that endoscopy available in each and every district of Meghalaya. And then these are other factors like dedicated facility, upgrading of the district hospitals, infrastructure, manpower, skilled manpower. Now there is a Shillong Medical College, 2 medical colleges in Meghalaya, so hopefully we'll get enough medical doctors in the future, oncologists from Meghalaya only who are willing to settle here and go to the interior parts of Meghalaya to do their practices. So that could be a boon to the thing. Regular funding, yes, government funding, NGO support. We definitely need the support of the NGOs and the private institutes in handholding and increasing the cancer care all over the state. Donations, government scheme including PMJY, MHIs, all will be important. Insurance scheme is already very strong in Meghalaya, there is no doubt about it. And patient support system, like logistical issue, we have to cover them for some Dharamshala or Vishram Bhavan. Like we have a patient staying facility near the Nigrims, which is from the Entas Foundation. There are around 16 rooms, so around 36 patients can stay. That has been one of the good boost for the patient to stay in Shillong for 1.5 months for radiation therapy. It is free of cost. They are extended the services, not only the stay now, they are providing free of the food also. Now they have provided the car also for the patient to transfer from the guest house up to the radiation center or the OPD on the daily basis. So these are the initiatives which NGOs can come forward and help in getting the cancer care more accessible and available. Appointment of the cancer support worker similar to ASHA by the government could be more helpful. Yes, one last query from somebody. Yes, please. Yeah, you can stand up.
I think it was during the tenure of Dr. Mukul Sangma that a state-of-the-art mobile cancer testing bus was intervened.
Yes.
I was sad to say that we don't see any skeletal part of it as well. So I feel that for more accessibility, especially in the rural areas, and as much as the MAX is doing, Meghalaya AIDS Control Society is having this ICTC vehicle office which is going to the outskirts and reaching out far and wide to the masses out there. It's about time that the state government, if not 10 of them, but at least one state-of-the-art, mobile cancer testing, if not anything much, but providing access to at least some medicine or reaching out, basically, would be just a great, step forward towards accessibility.
Thank you for that question. So coming to that point, we already have a MOU signed with the Grace Foundation today, who are going to do a screening with the mobile vans in the West Khasi Hills districts. And the State Cancer Society has already taken a project of mass screening and they are in the process to start. They are already done a screening in different villages, going with not a van as of now, but going with a different vehicles and approaching the village, doing the multiple camps in the periphery, and that is going on initially. And this will be started with a more upscale version in the coming months. So, Nikki, yes, you will be required more to propagate that information through your media house, and that will be more helpful, that this information should go to each and every person, and none other than you will be the better person to do that. You should come forward, and we'll be happy that you contact the State Cancer Society to do that. The information needs to be sent to the other people. Thanks for doing that. So with this, I think I am above the time. Thanks to all the panelists for their inputs, and thanks to all the public for their participation. Thank you so much. If there is any question, we can discuss it for the next few topics. Thank you.
That patient has cancer. Sometimes we also as doctors, we try to say on the first visit, I try to tell them, you have some tumor is there in the esophagus. So there is a lab lock, that much Kasi only I speak. So I tell them there is a tumor, lab lock. So then on the second visit only, after the biopsy report comes only, we can technically tell them it's cancer. So many times on the first day, we don't even tell them that it is cancer. So such a bad disease, at least as perceived by people, do you think we should talk about it to children? Yes, each of you can share your views.
Hello.
Yeah.
Thank you so much, sir. My name is Reverend Precious, Principal of Vivanta College. Actually, at the outset, I'm very happy to be invited to be a part of such a conclave, because oftentimes when we talk of cancer, we talk of hospitals, of awareness, of campaigns, of making people know what cancer is all about. But oftentimes we forget that, as you have mentioned, awareness should start very early. And I think the right place to do that will be schools and colleges, because that's where habits are formed, where students, where young people are taught how to behave, how to live with empathy, how to sympathize other people. And I think that's also a place where we should make cancer awareness like a lived-in reality, where we talk that it is one of the problems that we are facing, and as students, we can always ask them, how should we contribute in altering the way people see it. So I feel like it should start early, not when it is already detected by doctors.
Thank you. Anybody else want to share?
Good afternoon, Dr. Caleb and this August House. I'm Vivek Lingwa, Head of Department, Commerce Department, Commerce and Management Department, Meghalaya College, July. I'll just connect what Precious, if I didn't got it right. If you talk about where students or children are concerned, a child will always hesitate to ask a doctor, but he or she, a child, will never hesitate to ask a teacher. A parent will just throw away the pamphlet, but she or he will always listen to a child. So I think like what Sir Precious said just now, it should start from schools and colleges. And I'm very happy that I can see Dr. Charmiki here. He had come to our college to, we had a program. We had a lot of parents with cancer and all that. So our students also were so enlightened at that point of time. So there was a rampant asking of questions every time, and so, they get that there's no such kind of stigmatization or any kind of taboo as such, because they were quite free in that. So to start from that particular level. Thank you.
Yeah, please.
Thank you so much for having us here from St. Anthony's College. The youth, the children, the students, they are actually very health conscious now. So, they are not only aware that they have to have a healthy lifestyle, they're into fitness, and they're also aware of what are the determinants of, diseases, non-communicable diseases, including cancer. So in fact, they are the best people also to advocate for cancer awareness, not only for themselves, but in fact they talk about this with their families. They talk about it. I'm from the biochemistry department, so we teach this as cancer as a curriculum. But the clubs that we have in the college, they are also what the students want is not only to learn about it, but they want to advocate to others. And through the club, in fact, we had collaborations with the NPNCD on diabetes awareness and all that. And we were privileged to have, I think Dr. Anisha was sent a team where we had cancer screening in the college. So, this cancer awareness is happening. And like you said, it's right, we should start early, and students are already aware. So the college platform, the school platforms are the best platforms to begin this kind of talk.
Thank you, thank you. Anybody else would like to share something?
Just to add to what everybody has said, I think we will all agree that teachers are the most trusted figures in the community. And when teachers speak, it does not end only in the classroom, the four walls of the classroom, but it actually reaches their homes. So when we actually start early, teachers start talking about it. And being a parent myself, I think my children will listen more to what the teachers say and will remember what they say rather than what we parents are saying. And when as teachers, when they speak about it, they actually create a kind of a ripple effect. A lesson that they learned in the classroom will actually become a lesson to the student, but that student actually will spark conversation at home. And that family discussion will eventually, gradually leads into the community, but will actually influence the community norms. So this ripple effect that teachers can actually, create in the classroom, it is very powerful, and I think it needs to start early, because they actually, they start early school as the formal education starts as early as 6 years old. So they're living beyond the classroom at hostel.
Thank you. Yes.
Good afternoon, everyone. Myself, Larry Verpo, a normal school teacher, English teacher from Mayfair Secondary School, Ankara. So, in addition to what panelists said, I just want to share one incident scenario. In normal classes, before I start my classes, there will always be curious students. And one curious student was asking me before I start my class. So he was asking me, sir, why is my father eating kwai, eating shikhar? Or it comes to the level where he was asking me, why, sir, why is my father, such a known drunkard? Why he always beat my mother? So it becomes a totally different scenario when the child asks you that question. So being a teacher, you have to go very cautiously. You cannot just approach, you cannot just be blunt. You have to think and you have to analyze. You have to talk in such a way where the child will not lose the respect for his or her, for his parents, but you have to talk in such a way that they will understand. And I think so as we progress in the discussion, we'll talk more about that. So thank you.
Good. I think after the meeting, you let me know what you told the child.
Good evening, everyone. I am Senchi J. Samma. I am a nursing tutor working in JNM School of Nursing, Northstream. So, as the question is, should cancer awareness start early? Me, coming from the medical background, nursing personnel, I feel like cancer education or awareness should start early, because in this advanced modern age, there are risk factors which small children, starting from the small children itself, they should know what are the risk factors that can cause cancer in the later life. So I feel like regarding nutrition, it should start from the school level. What other, the students are carrying for tiffin, teachers, they should see to it that whatever they carry to the school, it is the food that is healthy. It's not like carrying chips or carrying fries. That can later lead to cancer. So, as my other panelists, even me also, I think, like cancer awareness should start early in life.
Thank you. We have some consensus on it. I think most of them said that children are very receptive when they are young. That is one reason. And then it can have a ripple effect from the children. It can go into their parents, other neighbors and other society members also. And I think one more thing is that it normalizes cancer. I mean, people shouldn't think that, I hope in the next generation, 15 years or 20 years down the line, cancer won't be looked upon or perceived as a very bad thing or a bad word, I guess. But then one more thing which is very important is that tobacco initiation. It usually starts with the school age thing. If you look at the data also, in the Global Youth Tobacco Survey of 2019, 42% boys and 28% girls, that is 34% of children aged 13 to 15 years, they were found to use tobacco, which is a very, very high number. Or in other words, we say 1 in 3 children of age 13 to 15 years, they are chewing tobacco or smoking tobacco, which is very alarming. And what do you think as teachers? I know Larry is the only one who's at the school, because I've seen even children as young as like 7 or 8 year old also, and we've had patients also. I've had to ask twice because we generally, when the patient comes to us, we ask them, okay, what have you been using tobacco? What age you started? Some of them say 7 years, 8 years. We usually ask them, so early is it? So that kind of thing. So what do you think, what has been your experience, and what do you think as teachers you can do to help in this?
So first and foremost, everything stems from curiosity. Why they are taking, why they are into tobacco. First comes curiosity steps in, and curiosity happens when they are easy accessibility and availability. Like it's a hub in the middle of the town, so there are many shops, many institutions. So children, anybody at the age of 18 below, let's say, they have very easy access to tobacco, even liquor for that matter, which is very upsetting. So how to put a stop to that? So we cannot just tell the shops to close or not, because I've seen some police from the government, they have restricted shops within the purview of the school within particular radius to stop selling of tobacco. But still there are some shops that are selling. So how do we put a stop to that? Because if the children get access to tobacco and all these things, at the end of the day, their curiosity will step in, because if they see their family members at home taking tobacco and all, obviously they'll be curious, they'll want to try. Even if the parents will stop them, they will sometimes school them. They will sometimes say that this is not good, this is bad. But I've seen one of my students, he became repellent and he asked his own parents, there was a PTM or something. At the end of the PTM, the parent came and told me, sir, please talk to my son, because I found a cigarette in his pant yesterday, but I don't want to tell him. But he heard of that and he came to me and said, sir, why don't you ask my mother, why is my father coming home drunk with a cigarette in his hand? So eventually the mother doesn't have any words to say. So she became silent, and ultimately it ends like that. So
the parents have to be role model.
Yeah, they're not a role model anymore, I'm telling you.
Yeah. So I'll ask one question. So do you think this scenario is worse as compared to when you were a school kid?
Yeah. Okay. Just in continuation with what Sir had said, because of the easy access, we've seen government has been taking lots of steps. It's illegal to sell tobacco. It's illegal to do this. But I think it's a human instinct to do something that is illegal. It's inborn in each one of us. And for that, each one of us should take a conscious step to do it. And we live in a society where we want to be polite all the time. Politeness will simply ruin the society at the end. I think it's time that as institution, as a society, we take a very firm step. Even if the shopkeeper happens to be our family members, it's our duty to report them to a legal office. Unless and until each one of us have that kind of a responsibility, I don't think change will come.
Thank you. That's a very strong message. I think that should go across. Because I remember when we were kids also, I think probably I was very curious as a kid. and I'm still curious. And probably I didn't take to these things because even the society, I know that if I try to experiment with something, people around will scold. So I think that sort of the entire society should take upon themselves that responsibility.
And one more, in continuation with what Sir has said, of how rebellious kids are. I think that is also something as parents we should look into. We are so much into gentle parenting, which I'm not against of. But I don't think as an Indian society we have reached that level as a Western society where we are so open with our children. So we are somewhere in between being modern, somewhere between traditional. I think that's where we should really work out on how we should help our children.
So let's be traditional.
I think that will help us better. Thank you.
Can I add? I'll just take what Sir had said just now and what Sir has said just now. I'll just sum it up into 2-3 words. Basically, like curiosity and etc. we tend to imitate. Okay. My father was in the army. He's always posed a photograph with a cigarette. And I've always seen that. And when I was a kid, I started posing with that. Okay, so, then it became a habit. Basically what we do, what we think about children nowadays, school kids, college-going kids, university-going kids, what we teachers, what people need to know. Who teaches biology? Teachers. Who teaches between myth and fear? The teachers. Who teaches about health and hygiene? The teachers. So basically, like Sir said just now, or you said just now, students would not listen much to their parents, but they will listen to their teachers. So this is something which I would like to say that we need to create a whole lot of awareness from every aspect, where tobacco is concerned, where alcohol is concerned, where drugs are concerned, every kind of disease which could lead to cancer, every kind of bad habit, which could lead to cancer. Because see, a kid would ask, is smoking bad for health? Is it injurious to health? But a mere poster, a mere hoarding will not catch the eyes.
And I'm glad that the government has come up with a law which prohibits advertising, even though there is some sort of surrogate advertising going on. At least the Rajinikanths no longer smoke cigarettes. Yeah. So we realize that the teachers are very good because, like all of you pointed out, the students listen to teachers probably better than even their parents. So, so can somebody talk about this law? How many of the teachers know the law? So I'm sure this COTPA is one act which can be used. But how aware are our teachers? Probably because you are sitting here, I know that you probably might have been the nodal person in your institution probably. But apart from that, apart from you, would all the teachers in your schools or your institutions, would they know the law? Would all of the teachers know that they should not smoke, at least inside the school? How is the scenario? Can each of you give your views, quick views?
So in our college, we have in fact an anti-tobacco club, which not only advocates for the laws and regulations regarding all of this, but also the determinants of many diseases, including cancer. And you'll be surprised, of course, these clubs are always led by students, and they have teachers who are their mentors. But you'll be very surprised that the clubs are so effective that, in fact, they go to teachers who they know smoke and advocate to them how bad smoking is and what are the causes of smoking. So, I mean, I don't know if this is done in every college or schools, but these kind of clubs, you'll be so surprised that if you leave these kind of, topics to the students, that they once they understand that these are determinants of because we've been talking about cancer prevention. I mean, cancer diagnosis and treatment, but cancer prevention. If you can prevent cancer, that itself, I think, is a win.
That's really nice. I think that's a very important takeaway. Maybe we can talk to the education department also and incentivize anti-tobacco clubs in all the schools. Probably that will go a long way. Yeah. Anybody else want to share their views on this? Yeah.
So apart from the law, having a law,
how do we actually reach these to the communities, because that's what the session, how from classroom to the communities, how do these different kind of education or different kind of knowledge that is being shared in the classroom reach the communities, and I think that's very important. And I think one question that we should actually look at here when we talk about cancer, we talk about any kind of health preventive diseases. Are our teachers, or as teachers, are we really competent in all of this? Does the education system allow to actually explore beyond the syllabus? And I think looking at this now, we saw with the new national education policy, they have rightly said, policy has actually, there's a paradigm shift with it, where they wanted to actually introduce experiential learning to the students. They want to focus on experiential learning rather than learning in the classroom, because when students actually have a first-hand experience in the community, seeing what people are facing in any part of an issue, or they have a first-hand experience in the challenges and the communities, I think that's a great lesson. And I think it's very important that as education institution, we allow that, we give that space, provide that space to the students to learn from themselves, connect with real life challenge, not to actually keep them only in a bubble that everything is fine, we talk about cancer in the classroom, but how about we try to connect students with the real life issues? Have we tried asking the student if they can actually talk to a caregiver? We have one caregiver who actually spoke wholeheartedly about her experiences, of her journey. How about we ask the student? I think that will create a lot of impact. That would actually change communities, and that, I think, that is what about from classroom to communities, and that's how we can empower teachers.
My focused question is, like Dr. Nogram, she said that they have anti-tobacco cells, and the students, the clubs, they themselves go and tell them stop even the smoking teachers from doing. But if you look at the Act, COTPA Act, no sale of tobacco within 100 meters of schools. So I often think, Shillong has so many education institutions, and it is so small a place that if you, for example, from Nigrims, if you count 100 meters, you will come to Nia. So from Nia, if you count 100 more meters, there is one more school called Sharon School in Modiandale. Likewise, if you keep counting, entire Laimukra, nobody can sell any tobacco. So if students are empowered, if students are told, hey, this is as per the Act, so you can question things, then the entire society can be changed. So how aware are the students in your institutions, and what steps would you take or are being taken? Like she said, fantastic. So like we should make it like a model thing. We should try to implement such clubs in all schools. But in the meantime, what other thoughts do you have? That's my... Yours is a nursing institute, I know. Yes. It's a bit, because students are at a different level. I hope nursing students don't take to using tobacco. But I'm very concerned about other institutions.
Very true. Actually, for us nursing students, we do have theory classes and practical classes and community postings. So whenever we get a chance, we have community postings in first year and third year. So during that time, whatever time we have, like for example 10 weeks or 12 weeks, during those time when we go for community postings, we try to make people aware about this COTPA Act, and but it is very difficult to visit all the communities. So whenever we have time, we make people aware that COTPA Act is there, and selling of tobaccos is prohibited. So when we visit those communities, I can say like obviously they sell those tobacco products, but they don't advertise outside. They sell it, like a weighted tip, used to say. So they do that. But yes, we do make people aware, and we create awareness, and we do give health talks and even role plays also.
Okay, so, okay, thank you. We need to be fast. Everybody will have to speak only 1 minute maybe, quick, or less than that.
Okay.
What would you do in your
just
school?
A point of view. Yeah.
I really appreciate, ma'am, for all the efforts that you have taken. To be honest, we have not really done anything as such. So I should be honest with myself first. I think as a principal, I have failed.
Yeah.
Because
No, no,
I've
it's
never,
okay.
I've
No,
never considered this to be
please
very serious, you know.
Within the next 3 months, would you be able to implement this?
Yeah.
That is the
what I'm
question.
thinking.
I mean,
yeah.
that is what we
So,
want from this, I think.
Being a panelist, I think that's where I also learn. Like, we
Yeah.
get to learn from other panelists, and I think it's very helpful. So, the thing is also, we do have teachers who smoke, and whenever they come to my office, I know they've been smoking. And I'll tell them like, are you smoking? And then they'll tell me, no sir, but still I could sense it. So anyhow, like on a lighter note, I will joke about it, and then I'll tell them how they should be to other students. Even though we have talks on anti-tobacco use once a year, I think that's not enough. So I think I should take your example, having an anti-tobacco club in the college, and I hope that will help. I think the steps should be taken while they are still learning, so that they can propagate it in the society.
Yeah, thank you. Yes, can you talk about what you can do to prevent tobacco being sold outside your institution?
Yeah, we've taken this. We've taken this step. I have complained to the principals, the former principal, the present principal. So we should not have shops selling cigarettes and BDs and all that near the institution. And I can I'll take a cue from Madam also. Maybe we should have a club in our college too. And, But we have we have hall signs and all that. No smoking zone. In the campus.
Yeah, thank you. That is as per the requirement of the law.
Right.
So that's nice.
Exactly. So, and we also have a disciplinary committee of which I'm a member secretary of that. So usually I punish them when I see them smoking.
Great.
Thank you.
Yes. Balari, would you like to something very brief, but
Actually, I have many things to say, but the time doesn't allow. So, if they will allow, I'll just speak a little bit.
No,
So,
quick response.
last year our school got the certificate of tobacco-free school.
Yeah.
But one day I was joking around with my principal. I said, "Ma'am, look at the board outside. It's hanging. It's written tobacco-free school. Are we really tobacco-free? Because to be honest, awareness is needed. First and foremost for the teachers, I think so. I think there should be an act where teachers should not carry any kind of tobacco or betel nut to the school. If teachers can do that, then ultimately I think so, slowly, then it will creep into the students, and they will, because students see teachers as role models. But if teachers are doing that, and there will be no respect in front of the students anymore. So, just like
anyway,
that.
but we are living in a democratic country. And even though it's not a fundamental right to smoke, we have to give them people that.
Institution, I think.
Yeah. But then I think it's very nice that Indian tobacco laws are one of the best in the world. And how many of you are aware of this tobacco-free education institutions, and are all your institutions tobacco-free? Balari said it's free. I'm sure Anthony's is free. If you have not done it, probably you can adopt it. And Meghalaya has done really well, and it's been awarded by the WHO also, that it's tobacco-free education institutions, this implementation program. And but it is not fully implemented in many colleges, I guess, but that will be the phase 2. So I hope in due course it will be done. So even if it's not implemented, so I mean, even if it is not declared free, are all these things being done? Like I'm sure, are there boards in all your schools that this is a tobacco-free education institution? And I know what happens outside the school is little bit beyond your control, but not totally out of your control. You can always enforce that selling of tobacco to minors outside the schools within 100 meters. I'm sure even outside Negrils also sometimes I've done my part also to complain, but it is not always very easy to enforce it. So that we can probably do. And regular tobacco control activities, I know we, so like what Dr. Nongram has said, probably all of us can adopt that. So, yeah, so this village health councils have also helped. And like all of you said, if the students are really inspired, they can take everybody to task, I'm sure. And that way, I think the entire society will be transformed. So, before we close, is there any message which each of you would like to tell? I mean, one last word from each and every one of you. Quick last word.
Yes.
So okay, I mean, these are very general. It's what we've seen from experience. Like I said, the NPC city has come to have awareness programs on diabetes, and so it's these many people are for them. But we've also had the anti-cancer screening, and there was a little bit of a challenge because I think the scare of cancer. So I'm not saying that this should be done always, but instead of saying there's a screening for oral cancer, if we say it's an oral health kind of an awareness, then people will come for it, because there's no scare, but at the same time the screening will happen.
Yeah.
So I think the mindset, maybe this is a message for the organizers, but the kind of a mindset when we approach awareness should be a little different, I think. And also, I mean, we students, like I said, I'm not trying to advocate us, but students, we have, like what ma'am has also mentioned, the NAP 2020 also emphasizes on community engagement, where students go to the community. And what Pastor said also about empathy, these are some things that we teach the students. When you have empathy, you see what is happening because of cancer and how it can be prevented. When I spoke to my guide yesterday, he was from all the non-communicable diseases. You'd be very surprised that cancer is the only one that, when detected very early, has a cure. I mean, if you talk about all the non-communicable diseases, you have diabetes, there's no cure, you have to manage it. So, I mean, the kind of approach to awareness, if these are addressed at the beginning, I think it will probably help the mindset of people trying to open up and listen to actually what cancer is about and how one can.
I've also realized that nowadays when I organize, I call it as a health camp, and then we do the cancer screening, and that is the way forward, rightly said. Reverend, you have a few words on it.
Just to add up to that, if you really want to prevent cancer, I think it should start now. And it should start with us, sitting right here, talking about it. I think the moment we get out of the door, that's when we should propagate what we need to do to prevent cancer. Then only I think it will work. Or else it will just be talk, we'll have a third conclave, and we'll have more numbers in cancers. Thank you.
Yeah, I would second with Madam Noor. Precious. I think so. They've said enough. So I want to.
Yes,
thank you.
To conclude, I want to say that cancer awareness, it begins with education, and education begins with empowered educators. So I feel teachers, should be empowered so that they'll be able to pass on the knowledge about cancer, especially cancer screening, all about the risk factors, right from the school level. Thank you.
I think that's one of the reasons why education institutions have been invited to such conclave, is that it shows that it's high time that we need to actually do a lot of collaboration and have a lot of interdepartmental collaborations between health as well as education, because we see that a lot of the whole morning we have discussed about the health-seeking behavior, and I think if we empower teachers, just like what Madam has said, if you empower teachers, then teachers are not just subject-centered or subject-centric that they just have to inform, but teachers, I see teachers as community connectors, and I think if you do that, gradually there can be a positive health-seeking behavior in terms of any disease for that matter.
Thank you. Yes, Vallari, last few words.
There are plethora of challenges we face as teachers, but one of the things we're facing now is students using tobacco. So at the end of the day, we need awareness, like one of the panelists has said, rigorous awareness, especially to the teachers and the students in the form of seminars, maybe one or two. I think teachers should be entrusted, guided, and educated first and foremost, and we can pass on the knowledge to our students. So for that, we need the government to conduct rigorous seminars for us. Thank you.
Thank you. Is there anybody who want to share any comments or any opinion? Yes, Vikas? Thank you, Vikas. Yes, Mr. Nikki? Yeah.
The state as a whole is working on drafting the education policy. It's going on at this point of time. The curriculum framework is being done. I believe through this August House, if there are good authors, we can definitely write to the Commissioner and Secretary, and let's have cancer as part of the health education subject, where these initial awareness that is needed in terms of symptoms, habits, or the kind of steps that need to be taken at the early stages, all of this can be part and parcel of it. I didn't see in the last conclave that I attended on the curriculum framework this being mentioned by anyone. I feel this forum itself could
Thank
be
you.
a great
That's a very
platform.
good suggestion. We'll try
Thank
to
you.
take it up.
Take it.
Yes, Madam, just 1 minute. Yes, yes. Yeah.
Awareness should start from you. So is there room to include this in your syllabus? Okay. Till school, I think I have, I also passed out from Meghalaya. Till class 10, we used to have health education. But what after class 10? Like for commerce and...
Yeah, but I think one of the key takeaways was that even if it is not part of the curriculum, because curriculum will take some time. Like if you have an anti-tobacco club, which we have the bosses, we have the principals of schools here, or main core decision makers in the colleges. So if each and everyone can have these clubs, I think that can itself, we can start with it right away, and before waiting for the curriculum to change. Last word from Dr. Sita Madam. Yeah. Madam is Dr. Ravi Kannan's wife.
Yeah, thank you. There are just a couple of things. One is, I think, yes, cancer awareness must start early, but more than cancer awareness, I think at the school and college level, promoting a healthy lifestyle and teaching the ill effects of tobacco use should be the focus, I think. Because if we talk about cancer to children, I'm not sure they will actually be able to look at it from the way we are looking at it. So that is number one. Number two is, I think consistency is the key. See, if we do one event in a school and talk about tobacco, that is not sufficient. It has to be all year long. An emphasis on a healthy lifestyle and an emphasis on staying away from tobacco is important all year long in schools, and therefore schools and colleges need to take this up as an important. Sometimes we get institutions that feel they have too many things to handle and they don't want to deal with tobacco talks and all that. And which is the way sometimes leadership and institutions look at it. And so that is important. This is a message that can be carried through to educational institutions. The third is, I think, to look at creative ways of getting children involved in these activities than just lectures. So there could be poster making, quiz, whatever, different activities that can be consistently part of the extracurricular activities in the school, by way of which these lessons are also turned. And then there are two other sets of people when schools and colleges are concerned: parents and teachers. So if cancer hospitals can take the initiative to get teachers to sessions where they can talk to teachers or visit schools to talk to teachers about tobacco, about promoting a healthy lifestyle. And if schools can take the initiative in inviting doctors or other professionals who can talk to parents about promoting a healthy lifestyle and about staying away from tobacco, I think these will be helpful in promoting cancer awareness. And one last thing, in a lighter vein, I know someone spoke about parenting being traditional and modern and trying to stick to traditional. I think we need to be neither. I think it's important to understand that as parents, we need to be assertive. I believe as parents, supervisors or leaders, we cannot always tell things that people will like to hear, but will in the long term be good for them. And therefore, it is our responsibility to educate our children. What emerges out of it will be their responsibility. Thank you.
Thank you so much. We are short of time. Only one thing I wanted to add, in addition to tobacco, we should talk about koi also. Yeah, thank you. Yes. Okay. It's not on me, please don't. Yes, Dr. Alicia.
One last one. We've been talking about students and youth, and also it involves the community also. And in a society like ours in Meghalaya, the church plays a very important role. There are those who don't go to school, but they go to church. So I feel like the religious leaders also have an important role in this. We have so many sermons in the church, but at least it can accommodate, these healthy lifestyles, habits that we maybe for NCD or for
I think we
cancer.
should tell the pastors to send them, to send them to school.
Yes, so I mean we should take church as a platform also to advocate for this.
Thank you everyone. Thank you, bye.
Hello, so too. Baka kansa kamde ke jingpang ba ubriu ne kibriu bale that maki ya maki. Kade ke jingpang ka ba ka society jong ni kampaton ke jing kle ban yang mentah ba de trailang ha ban ya da kata kudish.
Thank you, ma'am. Since I'm a radiation oncologist, I come in contact with cancer patients daily. But if I talk about my personal level, I first contact with cancer patients, my uncle, my younger auntie's husband. He also was diagnosed with throat cancer. But he has a risk factor. He was alcoholic and takes betel nut, so he had cancer. That's my first contact. Then the next very close is my best friend's brother. He was an IRS officer, and he's a young chapman. He's a young guy. He's married, just recently married, has a child also. He's hardly in his early 30s. He was incidentally diagnosed with CA appendix, which is a very rare cancer. So that was my first contact, and I have seen him. Like he's a Rajasthani when I was doing the PG. So he's a very tall guy, very well built. But because of this CA appendix, he's deteriorated. Like he became like very thin, cachectic. It's unrecognizable. So that is, I think, one of my first contact with cancer patients during my residency.
Thank you. So it would appear that everyone in this panel has had first-hand experience with cancer. Now, there are many myths about cancer. There are some people who say, can biopsy, when the doctor asks you to go and do a biopsy because he suspects or he or she suspects cancer, many people shy away from that because they think doing that itself will cause cancer. That's a myth. And there are some who think that if somebody in the family has cancer, then it's inherited. So we have talked about cancer a lot. We have experienced it in our own homes. What we haven't spoken about is the need for a peer support group. When somebody in the family has cancer, there's a lot of mental health problems. Maybe not so much for that person having the disease, as much as the family members. And from listening to Nick, I can imagine how traumatic it is. So why is it that in our community, we don't have these peer support groups that can help us, can help with counseling us and maybe show us the way forward? Because very often we grapple. We don't really know what to do. I remember seeing my grandmother once. I think she had, she had uterine cancer, and she bled so much that we were shocked beyond words. And only when we took her to the hospital did we know that it was cancer. And by then it was too late. So much has been spoken about help-seeking behavior. We don't believe in these yearly annual checkups. We don't even want to do blood tests and all to see how our liver is functioning, how our kidneys are functioning. They had to bang in the lap, happy clock. When we are really feeling that we can't do anything more, that we go to the doctors. I think that is something we should, as a society, take it upon ourselves. And young people like you, I think we have to tell our family members to go for these yearly checkups. It's very, very important if we want early detection and early treatment. So, there's this saying that cell phone towers can cause cancer. I did a lot of reading up. I'm not a doctor by any stretch of imagination, but it says that there is not enough data to suggest that mobile phone towers can cause radiation strong enough to cause cancer. Then we come to, just recently, in fact today, one lady is being buried in Palorsla. she had been suffering from cancer for a long time and then was treated in Bangalore, brought back. And her brother, educated young man, went all the way to Arunachal Pradesh to get herbal medicines from a particular lady there who it seems has become quite famous for that. So now we are not doctors here. We would like to hear from doctors, in fact. Lada kita ki dawai kembat, ki arab ne, ki miarab ne. From all that I have read, it seems that if you have these herbal medicines, especially while you are on radiation, then it might interfere with the whole process. So I don't know who's going to answer that, because I don't think anyone. Oh yes, please.
Thank you, madam. So the lady was speaking about Arunachali lady, that the herbal medicine. I know about her. Like we do get patients coming from her. I know Dr. Lamin's patient personally had gone to 3 patients. Yeah, but of course, no, they are not cured. They all come in the late stage, and ultimately they come with liver failure, kidney failure, which will become very difficult for us to manage. They come in the last stage. Maybe psychologically, maybe they give comfort, but I don't know. It's not. I don't think. I know it doesn't kill. They come with lots of side effects, which is very difficult for us to manage.
Is it just a palliative?
It is like a palliation. Maybe they get some comfort. Maybe not palliation in a sense, not a symptom. It's no. It is psychological, I think.
Then there is this latest data which says 39% of men and women will be diagnosed with cancer at some point in their lives. Sounds quite frightening, no? I hope this data I got from the internet, and I don't think it's wrong. So, what do you think of this data? What do you think, are the lifestyle changes that should be adopted if we want to not be in this category of the 39%? But of course, like we keep saying, no, to bri uyap ngatrai throat cancer jadi budi kia lene big secret palat. Then somebody will say, oh to bom judi bom jubang uyap cancer kumjoy.
An answer to that. Cancer is not only caused because of a lifestyle also, it is because of genetic and hereditary also. So 20% we cannot cure, but 80% is lifestyle. So that we can cure. So we cannot do anything about 20%. Our aim is to see that 80% of the cancer that comes to us. That's why they ask that we don't smoke, we don't drink, but we have cancer. That's because they may have some kind of mutation, hereditary, or be there in their family members.
So you are saying it can be inherited, can be hereditary.
Like CA breast, so many are there, pediatric cancers, and so many are there that is hereditary or genetic mutations are there. So 20% we cannot do anything.
If we see, just a while ago during the panel discussion prior to us, where it's been categorically mentioned about the age category of young people who are into consumption of some form of substance, is itself an alarming note for all of us. I'm at my 45, 46, and if you look at that statistics of saying 13-year-olds, 12-year-olds, and who knows, it can be even lower than that. That itself, I think, should be alarming enough for us to be accountable. And thanks to this conclave, hope this is an opening or an awakening for the people to realize that, hello, it's not that we are looking at when you are at 40 and 50 that you might be having symptoms. But quite frankly, I think one should, I for one would say that 30 should be a good age where you should have at least one full body test done and try to see and seek whether there are any signs, symptoms or not. But otherwise, quite frankly, it is indeed very alarming with the present trend. They're all addicted to some substance or the other in some way or the other. Hence, I believe that it is all the more important that the amount of awareness or at the same time preparedness has to come at a very initial stage.
Yes, please.
Kumbaong ikom, tapi sengap, kalau bukan persen, chance bagi minyak cancer, pet lagi, banyak, discussions kita ada pasal ni, numbers, statistics, penting smith ini, mereka cikli kita, atau nilai yang berpengaruh percentage, from 39 maybe to 30, slowly 25, 20. Te kaya mo kapan ang hakajing slow jangan simet masoma bahwa Meghalaya can never be a cancer-free state, but let's say we can reduce the risk of getting cancer. Mo tanah try kata tu nilai kan, le. Karena so, bahwa keren pasti lawan orang kadai lifestyle dari kau, dia tak paham kau perlihat kalau itu tik ke pollution tu kadai kau bahwa you cause of cancer, nampak jungi. Tengah semua kini berkait ni happen check ni lifestyle jungi ke surrounding ke jungi. Kumno pergi penkoi, ni melak orang pergi imsak ni pergi. Dan kalau kumno pergi long ba kanuksan ubah kan. Mo apa ni kalti ubah ni long ke healthy ke lifestyle ke jungi ke healthy ke melang kesalahan ke jungi. Suki ni reduce ke ni kan. Tak.
Kung abay bagani kan number ngarung so ay takajuri jing so jong pingam sukop akan de ro bakla namar bala dai ni wan yang sikatu benta mga kedo ne riyeng kesan bujogi la kumno iwe na kalai pumut iyo cancer bed but iwe ni san pumut ki bang itu ki dan big bayo cancer tingam tharai kan ding bakla but kadi katahi ki ba borok ni laya sam ni ba kawin ki bangilak control ke lifestyle bujongi ke bangilak ban DEA tinre harway day ba kata ka har pating kita ki cancer bi har pating try kata kan kalong clinical sin na kaliang jongi experts ban treat ni ban identify ban diagnose tinre unique numbers kilong alarming shisha but kimlong do bakla kan
Doni ay ban ong dapai
Baik, kau sih. Aku berjuang dengan apa kaji hek jom kelega percentage of cancer kelega long. Oke bagi beri jongi tang ayok cancer last time country yang di buat ban mi syafat ki beri anta kadon kata kita komperkat jongki. Teh kerja secara lelaki don kata kerja sul gelak kan ada dia. Jadi gelak tu ban kuat mangan don pun perlu balak kuat di Jepang cancer. Manta aku bisa buat jadi kelah kau yang jingkang kansa. Te ngai ong ba ya kansa banongkong ila ban pendunai ka banongkong hi dai bandan jing ai sen na perre perami. Dai ban buri, dai ban ye thoi shai, ye ka daw jongka kumno kawan balada kawan ro, dai ban jikre ban ai sen dan. Nak kerja ni.
Menela don jiba ong ba ki balang ki don ke bentar ke baklan. Kebadan bol ban pensutu ini ki hindai ngasno ba ni dangi ong balang don di bomdei ka tu balang ni ka balang ni bomdei ka balang hiru te ngasno ka snong hi ka dei ka lempung ba biang ban ai kini jing pensutu kini jing hikai kini jing pensyai dei te la dalek phai nang ni phin le ai nang tang snong
keburi di oi kong ka snong lam badan bol. Amar menilai sudah bersajak baik keren biar di diri di secret mana baik MC dari Shillong ini dari kita lagi bukan mo.
Em kadai ka Shillong ban pet
Shillong ban kapor
ban pet lupa itu hidukan ibati hajan di school.
Ada di school kan. Te mungkin ka Shillong kalau baik kapor bakle ban pet ban ta banyada. Ya ka jingkiu jong kansa. Namala da ka Shillong ka shibu jingkle. Kini kita beri juga Shillong tu kita kerjanya training rangkat bagi Shillong training rangkat bagi health department. Ini kan berarti ya, bila penduduk akan berapa.
So tenat banyak soy kata anda dede badan kita buat Shillong di badan lak mukra ganjil dalam kam kia kan dengan jingin keren deh. Maglak mukra ada bon tamki dukan. Bon tamki school, bat di college.
Kedai kau buang biru. Kumbawa mo pi bagi Shillong kita ka bentar o kraw ha hakabat pet perman mo Lagi pahit tiap akapor kubit. Kat no keserkar kesini additional. Nanti buat identify yaki patients nanti itu kibaran in contact with patients. Kat no keserkar kesini. Dia nak try keserkar di barat setiap society. Pada buat empower dia kesini pada ibu. Syuhud ngomong kesini ngomong buat. Kadang buat perman ban lek kini kiki baru kau ban ngomong ikut ban check kita kehidupan kita di jingdi. Wah, jadi biri jika rumah kita tertentu, mengacu air usaha, mulai jadi nama kau itu wine store, maka kamu buat kaji pembelian wine store pembelian IKEA, dah itu wine. Dan terus apa duna apa tu lesi apa duna apa rutin dia kata. Kadang di kaji ngerap ya kaji pembelian juga wine store. Tapi kemudian benut pan bu wine store mulai, boleh nama apa? Kita personal iklan, kimai nusi terus kimai. Dia bagi iklan kita personal, ka disiplin ru kinam sosial ru itu di balak dia kata dia nak try ke bawah ikut pada kisnong di isim dia kini buat let's say harusnya akan kata basket concern society buat keserkasi kumno bagin ya try pada kontingnya ya kan penduna ya kan cause of cancer agak celaka cumi saya kan try eruption
kalau bumne mo kasnong pada kayo ka bon na nangi wat ba Kadangi kipat ba ni pen bore kis yaki bors nong bakin khangi gitu gidukan tibade hajan jom ki hospital ru pe hana sarat shaban ru hana sarat duai ani tip shu ki dukan ayon tu pomdon shu mo te kadangi pe shwa tangi gitas ki lihat ru nginwan ra ka cingkela let's see how news number 1 la kamduna kita ki bayo pang cancer
Rosong si ulang ba, pada ulang ba senang usung di script pempum. Ini kita lihat jian sedang tang lanula amen dalam isyabar di script pempum. Tu baku pemkuai ekor nong ing maneru. Nih kita kum rumah nong dah berburam mo. Kata kalau pekalong ni kawai kabang ni hapan pek hamni kalong. Kabang masuk tu wakha ing lajong ru. Bapleng ipa katu kejinok adik jungi ban bam kerni jungi ban bam kini. Balakhin ustad tomon anu proud of kandai. It's the time when he will sit and he will make his own kini. It's not that he was buying all those the ones available in the market, but it is almost like religious for him to do it. So does my mother also joined along with him. What I realized is that actually it percolates down to the children who are witnessing it. My father was an alcoholic, and I realized that how many more such households and these young children who are growing, and let's not even talk about single parents and all of that. So the trauma is actually percolating right from the childhood stage, and more so it has become almost for them to say that like a trend as we talk in these days. Like you have seen, Juba Kesari. My God, I mean, if that comes. The young children think that, this is the swag to go about doing that. However, imagine I've seen students as young as 14 consuming 10 packets at a go of gutka. 10 packets. Another thing that I would like to highlight here, just to let you all know, I'm a teacher as well. I teach at the secondary level and try my bit, of course, how to contain that in our school. What I've noticed is that, see, it does not begin straight away with gutka. For the ones which is the most, I've seen the most common case of cancer, I would say, in the state. Because what I've noticed is that it begins with this thing called sweetie. Have you heard of sweetie? Some of you might have heard it. So the sweetie is not gutka, by the way. But it has the same tendency of making the child addicted to it. It comes, how much, madam? It's a small. It has supari in it, which has a mint flavor in it, and it gives you kind of a... Now, these children, you would not believe, are consuming it at a number of near about 10 packets per day, 15 packets per day. And the next stage, you would see that eventually they would be having gutka. And they're so addicted. There's a parent who came to me, they said, sir, if I don't give him 10 packets of gutka, this child, he'll kill a ruckus. And he can't do anything about it because there is no rehabilitation as such for him, for the little child. And it seems it has kicked into his head so much that he would do anything and everything to go about and get that packet of gutka. So, summing up, saying that we need to understand that where actually the root cause is. And back to the same old phrase in Khasi when we say na la rum pe.
I would also like to add. See, we've talked about the age where children have started consuming tobacco products. I see in the urban and rural areas, there's quite a difference regarding the age. Like I said, I'm from a very remote village. In my village and in any other villages, like this is very funny and sad at the same time. Children of this age, they are smoking together, they are sharing the smoke with their father. I don't know how they do it, but they are. They are going to the field, and then when it's time for lunch, they are sharing the smoke. They are sharing it. And what I realized here is that in the rural areas, it is the awareness programs is very important. Very important. More important maybe than in the urban
You have
areas.
stated the problem. What do you think can be done?
Exactly, ma'am. That's what. See, in rural areas, see, awareness programs regarding cancer and all, very less. I found them very less. Comparing to urban areas, like people in urban areas, yes, most of them are educated. They can understand easily. But in rural areas, I don't think so. From nakasispa kat nomot iban sumpo lada pikiran Jepang kani ka Jepang kamtam. But ngataray lada kasorkari bat ka health department ibarak away kin shimkia ya kani kabantang ngataray nothing is impossible. Long ka nginla hiban kumbaong ba mene nakalay pukanda siya kalay pro ngilapan pengia.
You don't come naman lagi snow ya ki volunteer te giban tremon semua wan ra ing ka program sa po snow. Kanang ba kanung ladawan nang ni ban ai jing hikay siya te kan long one off. One off kamera pi. Nang to na snow hi de ban don ka jing ayu kan ka jing don kam ka jing sungkia.
What we've seen is that the kind of awareness that we give them, so according to you, what will be the best for your village? You can think about it and tell me later. We will take that into
Every village will have a different model of that awareness creation.
Because cancer day, like you put a hoarding day, as soon as they see that, they will turn their face. No one will want to look at it.
Yes.
Yeah.
Yes, ma'am.
Tapi kong mengi kumasong deh ni isim sikit NCD program ni deh kado man putu dulu ni house visit. But still, we don't keep read bang tre you. Even job one day you one program NCD more free of cost, new shifting COA. But still, kim tre man le itu test. Dia orang test sini, test ini. Itu cukup ini saya kan.
General testing, it's a mindset change.
Yes, a
mindset change because we are living in denial of many things. You know, not just health, but many other societal problems also. We are constantly living in denial. We have to have a holistic approach. In shim tangika health aspect economy Amran.
Kadai atat mo ka awareness tentang tamtrika wat ha urban area luko. Baling om ka sarkar jela katrish dom ba bersutu ispan macai kan gibiu wangi ilai kendu ni kilo ni yo pilih you macai es lah lo makhot depan Jepang ni. Kiti te wat you ada haru banne ko bo ni doktor mane banne ada haru tre kita pension nguro benbol banne ada. Tingilap ke bor khoi ba tentang awareness kam terikam na ba sopat ko bo iko baka ngidon kami ka mindset change jangan suki ka approach ngidon kami kat bagi nak konsul tu mata pa haba pipet pa ya kan numbers suki beri pula ada hak ko state anak kiyo kelas tu ngidon kam jangan try kat bagi nak ya cakmat hi ngidon kam kalau consistency ka awareness ko juni ka approach ko juni bo biang kan nyerap.
We have talked about other things, but I'll just talk about the myths that comes to us in our clinical practice. Like first thing, they think that why I have the cancer. So they think it's a curse or maybe a punishment given to them. So we have to tell them that it's not a punishment for anywhere. It's a medical condition which can be treatable. Okay, and if we come in early stage, it's 100% curable. And they think when they have cancer, it's a death sentence. So we have to tell them it's not a death sentence. You come early, you take the treatment with modern technology, the cancer is curable 100% if you come in early stage. And I also want to say that most of our attendants or the family member, they ask us, is it contagious? They ask us, can we stay together with the family, with the patient? Because sometimes what happens when they come, they have false smelling. They cannot tolerate. They think that maybe it might get infected to them. So we have to tell them that no, it's not contagious. It doesn't spread through your living together or from the utensils that you eat. So, but instead we have to comfort them, to give comfort to the patient. And another thing that they come to us is like traditional medicines, like you said. They go, first thing they said, they said. So I said, no, I used to say first, when they say like that, I said, no, now since you have come to us, we have all the facility. Now the financial burden is also not on them anymore. The government is taking that burden for them. So you take this, I used to give them an example. Like, they say that, it cannot be cured, especially religious patients. They told me like, why, regarding the punishment from God, and why they are not showing the way to me. So I used to give them an example. Suppose you get stuck in the flood. So there's a saying like, if there was one man who got stuck in the flood, so he prayed to God, saying that why the God is not helping me. He's praying with all his heart. So, but a boat came, and they said, come, I'll rescue you. He said, no, the God will come and save me. He said, no. Then again, second time, and third time also happened. Then he died, it seems. Then he said he went to heaven and he asked God, why did you not come down and help me? He said, no, I came down. I came to you 3 times. So you should be, should take the opportunity when you come to us. We are not saying that we are God or anything, but He has shown you the way to come to us, to take the treatment. We are going to help you out. So that is one of the myths or the beliefs that our patients they have. Another thing is, like they said, only smokers get cancer. No, it's not only smokers. Even non-smokers, they get cancer. Like I said, it's hereditary, it is genetic, so that we can't change. But now with modern medicines, we can still, take care of the disease. And another thing that I would like to say is, sometimes they said cancer is always painful. But cancer in early stage is not painful. So by the time they come to us in pain, it's already late stage. So when you have the symptoms, it's not only pain. And sometimes what happened is they fear taking the treatment. They said the cancer treatment is worse than having a cancer. So, but that is also a myth. With the different medicines that is available, we can reduce the symptoms. Because we have to we have to see the benefit of the treatment, which far outweighs the discomfort. And which ultimately, if you take the treatment, it leads to a positive outcome.
Thank you. Nick, beginning from you, what is the message that you take back from here to your school? A very strong message on cancer.
Before I answer that, ma'am, I would like, with an honest heart, to thank all the cancer survivors. I would like to just name one. I hope she doesn't mind that I'm taking her name. With huge respect to Wari. And of course, we lost another one, beautiful soul, who fought the battle every single day on social media, posting hope, saying that I'm not going to give up. I guess, being a social media content creator, I'll tell you, no matter what kind of awareness I do, but what I see every time, that light of hope. Every time I see Wari's videos, it tells me and reminds me of how the more it's important for us to support this cause. So I want to really wholeheartedly express my prayers, and may the good Lord be with them as they are fighting this battle every single day, and may they overcome it. As to add to that, indeed it is so important that as someone who is an educator, to be able to, we always have a yardstick that we try to put, but I think with this day and age and the kind of generation we have, there's no point anymore. Until and unless we are able to talk through them and get them to see reality. And what I've done is, I lost another known person by the name of Ganesh. He had a mouth cancer because he had gutka. And I brought him to school one day, and he was willing to come. I mean, this is so touching that he came and he said that this has happened to me, it might just happen to you. So, I would say as a content creator, definitely...
We need to wind up her, so
yeah,
please hurry.
as a content creator, definitely taking steps forward to work with the State Cancer Society to spread as much awareness we can, and of course at the personal level to do whatever I can through My Meghalaya, My Pride campaign as well.
Check. Naka jika kabang ngayeng sa creator, but naka jing experience with jing shem gajwa. Kalong ba kidon ini ki myths and misconception kadaw kadai ba ya ka awareness kabangi ai nakalulu kalyang tanah department and nunu bentaru, it gets lost in translation. Ki babun bah ki pai ba kimla ban process yang tu information bikin smooth itu information nak takadaw kimla. Yang semua badai beraingu ika health department kebala long very proactive bikin semua tu lupa ikan ni bad layo bania tray bun sian health department bingin nyela banchna ikitu ki ads but ki belong very informative ki belong engaging tuju kapor funny at times but kawin ni ki bal along very impactful kebila jer kerteng ibang ni ki mentan kedai bad Yasmin bangkah dua play ki ba katu ka minute ka BI tang arkan ta BI katu ka life story jong BI ki bowan sha ki bobun bhai bowan sha ki ong bang yu i to interview ta kadam ni lech sha ka jing sha sumar tinga i ba kadi ka sinjam ni don kam shim khnang ba ngin mitigate ni myths and misconception number ba ki brio ki nam smuthu la da phi batai dai la da phi pani but phi yatho phi I experience kan irapshim rishmu.
Okay, I'll make this very quick. As just doctor have said that there are certain patients like there is always a battle between the traditional medicine and the modern medicine. I've come across this friend of mine. Her father is a cancer patient, and I reached out to her just before coming here, and I said, "How's your father?" And she said, "He's fine now." Did you go to hospital or visit a doctor? No. She said, we went to a Nogsumar Khasi and he's fine now. Lalet Shajintray, Lalet Rep Shabri, Lalet Rep Unto. Oh, okay. So, anything you have to say? I asked her and she said, no. So, Judan M has Shillong, Kajudan M Jinkaran to Kibri, by Pajabi of cancer. No, Kibri Shani is Utopa. They have a day, but modern medicine. What I found out is that there are some patients they said that it's too expensive, and what I ask, I just want to. I know I might not have, I would not make much of an effect, but it is my small humble request for the government to at least provide free medicines if possible.
It is already available free. MHI says everything is free.
That's why I said like awareness program again. Make them be aware of
so
everything.
you can go and take that message forward in your Shillong. Now please hand over the mic to him because we don't have time now.
Your MHS country come they magi bingalam hekiyem. MHS country come magi lady treatment deki nana actually have LCT have kana parante radiation free. Chemotherapy kita kishim shiten, nama nakalong mereka saya ke kebun mana dia kishim. Henry ke MHS the majority klabun bakal yarap ya ki longi ki baduna ye kata ti shu awi ki brio ba ka MHS ki dei bha ba ke enroll na mar ki dam dan Shillong ru ki ba duna ban enrollment ne ka MHS.
Kani kemudian kami commit about Aadhaar and all that.
MHS is a must. Ba ki dam dan ki om ki long ye ki Aadhaar de 666. Thì how come ngandi 666 mo Aadhaar pinon ka ma ration ka pille kinon kiling bang account pinon ka be ka Aadhaar ka epic bentali la kham tu na ba ki jing pan dei te war hashtong mangil gina paso thu ki bri o to jing pan to 666 dei ka dei ka jing su thu ba kla jong phi na ki para ma jan jong phi henre ta dei ada phi pang phi to manta pinon ka me ka MHS pili pan nang mo ka pisa pin pan ram pin hap sia zo ka sun MHS ada cover at least 40%, 60% kan cover nak MHS. They buat nak beri kilong ni unless at antul nak lapoi hospital then kisa phone ni kyo call ke MHS ni pattern. Yung sa register to shandor Aadhaar then you have isha you have an pack itu documents kin sa le hapo hospital.
Take a message nang ni kepada bandit mentas Shillong waper kada yani that you please register for Aadhaar.
Just is a must.
Macam likely ke bang. Kau balik kau ke misconception dari kau. Andre dia maksud tu ke demotivation. Ke demotivation. Ngawan nak Shillong nak mulai di constituency ke bahaya. Resident patient apa masuk kenam ni PHC. Tanpa kamu nak bandai dengan cancer. Kamu cina, apa kamu cina. So, tiga mang kuat banong kalau ada long kepala SC lingba. Kini ke program semua figure cancer society. Wa mau menurak ke semua regular kamu menurak ke diagnostic center kamjan sikipat ba jom kita ko apa aktif friend ki on medication treats the disease support treats the patient timbul ko ngene ru te ngatrai midor kambai kata ba ngi lama beli ki brief kilong silent ki apa cancer ngimnang kira ngimnang ban approach tu lah tinggi di benang ba banaga emotional and mental support ya ki patient ki bayo kini ke jumpa bat kepala ni ong ke MHS ai sing rap siya kamlan ni kata te don ki dawai ki ba 4 panel hapo ke MHS te ngasu itu khana ni nama ngadon personal experience aku por mi sumar na doktor I recommend da immunotherapy ke course silak stel ko injection te MHS cover te ada pilih makana ka immunotherapy intip patient in ne dan bisa kalau ini di UAE nanti kalau arm melalap ka lupus semua di abang gile ke tes pat namata ka napo ka private hospital balik ke CT scan tamla ban ayu ya ka ban ot napo MCS kamar balik ki hable share ka ultrasound sale ka CT scan apa di private hospital di kejar tak ke ma phone che masih es ada fesu ke omla ada ke prosedur hable kita kita ke lupus mengpak pensau ni ba kina pentibit pada kikum trekam joka smart ki jogi temitahi kubur pejibu
Kalau cuman banyak ibu ibu semran ngasu di kata biong bagi haki PSC kiduna kijing test deh. Ting lu kumaga mangin ako ka VSC committee ting ipa ki patient kung ki nong pangas no mo kiling test ki des spesifik ni hangtu ting undala poi hangtu ki ang bamton stock government stock come down ting mantu ki refer pacha kiwe ki hade ki support private ting katuro ka jinjar ko mi ki VSC members bagin I'm see mi ki bri bagin ki dispensary ni jake kum ta bisu ta terem ting kum ki jimpang ki ang test thyroid shipna you don't out of stock. Tika ingin ay men si mi kibre bakin de yakinier bhai ke bakin di ay jingsuma. Tika ta tika junja bhai ni bagi kibre bagi community em ni suku bah. Tika kibre ni di bhai ni shate shu wis like a pon. Test room done. Tika taro ka de ka way. Tika out of stock. Tika ka junja kin lagi kung ka dan pet kita community ju.
Ngaku akan nak kendian mo matakun no. Dengan jomga ngaku akan hukum di perkat batang kibri bayokan sar hijab. Ma berang ikram bayokan sar traida tak bayokan sar hijab bayokan sar ini imsa ani betul. Nama aku akan hukum di ba ide ban peduna jaga hijab bayokan sar. Ada kadang kiu di garit kalau hijab burung jaga garit bayokan hijab kibri jomi. Kalau lihat jom helpat baik kalau pengkres ko dia. nagaliang jongki doctor ki bala wad ki start prepare nagaliang jongki awareness program prepare kala na ai ti kalong bak hadin do kwa ba por berstiligi ba nado na layin ko mo ibe rang ba hado la Shillong ba hagari ba je baru bi de trailang narbanta ban penduk khot ya ki jingkiu trong cái chính nhập là cái kita trong cancer.
I don't think we have time to get questions from the house, so we will end this panel for today. I hope that we will carry back this message, especially the influencers there. You have a lot to be, to tell the public, especially the not so educated public. I think they are the ones who really need information, education, awareness.
Maybe they must have gone to the traditional healers or so here I think at the community level we can stress what Dr. Arvind had mentioned earlier, that the role of traditional healers we should take them into account in order to convince them that there is still hope for those who have been detected early, so that they go to the maybe to hospitals, to civil hospitals, Shillong or any other hospitals where they could get a proper diagnosis and treatment, and then we could have a good survival rate of such cancer cases. So in order to, yes.
Regarding the involvement of traditional healers and birth attendants, when this MHSSP came into action, so we have started training them. But the thing is that they didn't turn up. That's the problem. For institutional deliveries and for NCD screening, like for monitoring and supervision at the community level, and for motivating them to come to the hospital. But the thing is that they don't attend the training. So that is one of the indicators in the IPA.
Yes. The IPA thing. So the last message from each and every one of you, since you are so many of you, from each cadre, okay, I want some suggestions, or it can be in the form of a message also, and along with a suggestion from your side. What do you suggest should be the role of the community in terms of, I should say, early detection, number one, and second one is improving the quality of care for the cancer patients. So I'll start first with from the district, right, or maybe from Dr. Cliff. What should be the role of the community in few lines, because 5 minutes left.
I think first we should ask doctors also, mostly from the periphery, rural doctors or community health centers. Doctors should also be aware regarding the disease they encounter with the patient. Sometimes like patients who come, especially I'm talking about oral cavity, is very common in Meghalaya. If they have an ulcer, so don't treat them for so long. Yes. Put them for more than 1 month, better refer them. Second thing about community, the community, I think regarding the awareness, like from beginning, like from the risk habit, behavior, and the involvement of the ASHA is the most essential part of bridging the gap between
the community. Okay. Next from the district, 2 of you maybe, 2 or 3 from each region.
So with regards to the community, it is very important that they take active participation, because what we see as far as our awareness program goes on, only the women folk would come forward.
Yes,
so
exactly.
there's very less male participation. Since the representatives are here, my request is that if the involvement of the male is more, at least for the awareness session, and also personally, how many of us above 30 years have undergone, ladies, cervical screening? Any show of hands? Okay, so very few. So it has to start with us first, being the health, healthcare provider. And another thing which I see is we need a strong referral system.
Yes.
Because forget about treatment, the cost of treatment, even to come all the way to Shillong, it's very hard for them to hire a taxi. So we have to have a robust support system, just like for mother and child health, we have CMSMS. These cases also, whenever we need to refer them, at least there should be that support, financial support. Some of the DNOs here, I know personally, they are spending from their pockets just to refer a case to Shillong. So there is where the loophole is. Thank you.
Thank you, Dr. Alisha. I think that are some good points that you made there. One is the male participation. I think most of the time when we talk about health care, many people that the earlier session there was a myth and misconceptions, right? Many people think that the health department is only for females, right? Because we've been talking about mothers and children. But I think it's high time that males also come forward in order to seek, the health care. Because everybody is vulnerable, right? It's not only the females. So I think that is one point that you very aptly touched. And another point is what you mentioned is about the support system. So those are two important points that you've touched. Yes, Dr. Singwa.
Thank you, ma'am, for the opportunity. I would like to say something. Actually, whenever we talk about the participant of the community, right? When we talk about the health-seeking behavior of the people, especially in my district, from East India Hills, it becomes very diversified. Why? Because as you all know that East India Hills used to be a land of prosperity, right? People earn a lot. But recently with the stoppage of coal mining, people are living from hand to mouth. So many of the time, like whenever we give this IEC or whenever we give the information, it's very difficult for them to turn up to us. So we should seek of an alternative way of income that will be done from the government side, which is not from our health. But one thing that we can do is that we can go to their end. But what are the hardship that we face is, all MLHP, whenever they go, they were never incentivized. They never get any support system where they go and travel to the community. And East India Hills is a district where, even though it's a small district, but it is a hard-to-reach district, where you need to work for a long duration of time to reach a village. So if we have a kind of support system from the program that we can empower the MLHP or the ANM, that they can go and approach, I think the message would reach them. And as Dr. Alisha have said, we do see many cases where we suspect a case of cancer. But whenever we ask them, please go and visit a doctor, even from their village to civil hospital Cleria, they do not have money. So that becomes very, very difficult for us. And we cannot arrange ambulance for them also. So if there's any alternative way that we can arrange for them, I think the program will run smoothly. And as one of the villagers said in an interview that I have done, the villager says that I asked them, why did you go to a community healer rather than going to the PHC or going to the district hospital? They say, we do not have money. So she gave me an analogy where she said that, doctor, in case of a storm and there's a flood, what do? You try to grab wherever you can. So the same thing here now, we have traditional in our village. So what we do is that we go to the thing that it is accessible to us. So this other thing I think we should keep in our mind as we proceed further, so that we can become successful in this program. Thank you.
Thank you. I think Madam has noted down these points. Yeah.
Thank you.
Yes.
Moi Dr. Beneri kato transportation. Akan mau ba haposno juri runaway TB patient. The TB patient em nila labrep di dawai na po dispensary juri ro. The nalingo ba balai na po nigrim na po to kapor kita le kata ka project em kila man shawi ta patient na do na yen. Wan shawan bo ba kita inform I kong la shai kata ba jing son shawi bi. Thik poi da kapor. Dab nang tu la yalam shapor nigrim hospital balai desk screening I barokai. An la dab nang tu kita wan bo biang I hadwa hi. But na lor kata ki di ai ki ba mi ki nutrition food I bak kata ka free treatment. Te balikin ka government jogi pakamala bali kita nakam ta ki nompang ki jogi. Kita ki wait ila ki wan chuan de ka project ka poni grim. Ad ka to ko po bagilang pet magikin. Te matai te TB patient ila kwet nantate. Te ngaling ko ka jogi appear ki kata ka treatment. Hadu ka Presuk occupation ru ba ki one shop ki da one on. Kim lut touch tingkar.
Kita nak try ki project sebelum short term untuk shutdown ki bakile. Kita ki belum ting dei kabayat boroshita. Ndrei ngin peje kita ki bafi fi mi madam bapeje ta program dan hangni maybe ila kita ki suggestion baki ai
TV ki baliyo TV shi tunja bhaba ki ya kimma ki haba reserve kali tinte ki nature dispensary dei ki haba na ki kantai ki tu tinte ki oni kong bai kali san spot ble abhado baki na de ki test kakta ki ti isne ki kum na ki VHC ki hi ai jinga ta bakat nu in la namang ifan jungi ri baret ti kalong ta ke hi ai man na ki bagi badon kam ken ki kam shisha ke jinga hi ai hi na bo VHC.
So last, we'll turn to the Ashas. Naliang jonghi ke snow ba kadi ka ba laban le naliang ka shnong ka thau le ni naliang jonghi kum ki Asharu banyarap ye kitu ki badon cancer knang ba ki laban le chim jingarap ha kapon ka biang naki health center naki dispensary ki hospital ki ba hajan.
Kubleilam. Tena kaliang jongi ki Asia lane kilong yalam hasnong mo ka ka bangia kendu kalong ka bahakamat dia ka bangila ban ajimut lane ban pastu bi ka detang ka counseling lane ki awareness program ka detang kata ka bangila ha bangila ong yaki ba haba pisngo ba pidan ke jingper lane pidan kanu kudu ke jing thut ha bangila dep screen ki untu da ki sibak form tingila ong yaki bangila advice ki ba banle chiki BCCC ban pha pe ki doctor tangkata nakaliang jungi ngila ban ong yaki nang tapade shubu la don ki VHND untu lawan ki health staff na po BCCC ka bangila ban snow la ne ban banah ki perlong na susno kalong ba ni khot ni were ki bakin long ki bakloi ban wan shakmat la ka banta bersngap ki awareness program bagi health staff ki wan
Ki kat kumba ong I doktor mene ba ki bun tam ki kenthai ki wan awareness kalau bukta ni ki shinrang ru ki wan ne ki wan ne ki shinrang.
Oh kata ka de ki shamon namara ngape ha baru ki program na de ha ka program jongka department ba pher ne jongka balang ru ki ba buni ki ba pois program ki de ki kenthai ki shinrang ki kham ja lani ki kham duna kata ka de ki jisha khamtam lei hasnong ru ya ki parlok ngi ki asya habangi tri hasnong ya ki parlok ntengi khamla on pastu henre ya ki rangba la dangi kren mangi ting teng kila omba ola shuya batai start ni ki breu katar badan namare ki rangba ka khamle on pastu namar maki ki long kham khlain ka pastu ba ni ki kinte ase katar
Shibun. I think to sum up this whole session, we have had a very fruitful session, I think. I don't know about all of you, but we've had some good points that have come here. Number one is the gender divide that we have seen in terms of awareness program. Most of the cancers, males are also getting cancers, even females, but males are not getting the information that they are required to get, right? So maybe we stress more on the male gender, or maybe instead of having ashas for only dealing with children, maybe we, and women, maybe we can have a male mobilizer for male patients. Maybe I'm just thinking out loud. Maybe that could be something that we could do. And other things, of course, the support system and accessibility of our health facilities. Which is why many people are going to traditional healers and others. But I think the most important part is the health-seeking behavior, which Dr. Anisha earlier mentioned. Because if we understand that the health of each and every one of us is in our own hands, we do not need people to tell us, look after yourself, right? It should come from within. So I think we should have a new strategy in place where we help people understand their health and their health-seeking behavior, and that everybody is not invincible. There are diseases which affects each and every one of us. So with this said, I thank each and every one of you who are part of the panel, and thank you to the State Cancer Society for this discussion. Thank you so much. So with that, I would like to go to to our first panelist, Srimati Aurelia Karwanlang, who is also the Assistant Drug Controller. What are the current challenges in ensuring uninterrupted availability of essential palliative medicines, especially opioid like morphine, across district hospitals of our state?
First of all, I'd like to thank the State Society, Cancer Society, for inviting me to be in this panel. I'll come straight to the point. Like holistic palliative care for cancer patients, focusing on the relief from pain and distressing symptoms, along with the psychological support and then spiritual and social support. So the drugs control plays a key role in evidence care through regulations of the Drugs and Cosmetic Act 1940 and NDPS Act 1989. Coming back to your point regarding the availability of
regarding availability of these drugs, opioid drugs,
availability of opioid drugs. Right now, from a drugs control, we don't have any shortage of these medicines. The only thing is that we need estimates from the centers, from the registered medical institutions to apply for estimates for annual requirements. And in case if shortage of any medicines, they can apply for supplementary before time, keeping in view like their stock position. They'll know from the day-to-day management of stock position under Form G, which they maintain each and every day. The stock position, they'll have the stock position. They'll know up to how many months timeline these stocks will end for them. Before the stock out, they have to apply for supplementary or any supplementary approvals.
Okay. Thank you, ma'am, for that.
Supplementary approvals. So they'll have to see the time taken. Like if they apply for approvals also, not they'll apply when the stock is out of the center. They'll have to see the time taken for approval, time taken to place the order, time taken to reach the stock, to reach the institutions.
Okay, thank you, ma'am, for that. And actually, we were very happy to have these facilities where licensing has to be done, because, as you know, we are also suffering from drug addiction problems in the state. So, and these, for palliative care, we need morphine, which is one of the, so very stringent control is being done, and we thank the drug controller department, where they really take they take this very seriously, and audits are also being done from time to time. So I would like to request you, ma'am, if we can have the license as soon as possible for the other districts who are still awaiting.
Yes, as soon as we get the means, they have to file an application in Form F. Yes. As soon as we get the application for us for processing of application, we don't take much time.
Okay, ma'am. Thank you. Thank you, ma'am. Now going to the district nodal officers. I'd like to ask, Lucky, how is the palliative care clinic functioning in your district? Could you please share any best practice as well as the challenges? Palliative care clinic.
Thank you so much, ma'am. For our district, at present, we have just recruited 2 staff nurses and 1 physiotherapist for palliative care, which was in the program for NCD as well as the national program for health care of elderly. So till date, they have, we are yet to give them rooms, because civil hospital, as you have, you know, ma'am, you have visited, it's very cramped and there's no space. So what we have done is for physiotherapists, we have started treatment and we have given at least those exercises and all for those long-term illnesses regarding the exercise that is needed. But regarding all staff nurse, we are yet to get that. So we are waiting for the construction to be done. But if we talk about the field level, regarding the palliative care that we have, RMLHP have done a tremendous job regarding palliative care, where they have visited the household level and they have trained even the family members regarding the day-to-day things that the family need to do. Because MLHP cannot do it on a daily basis, so they train the family member, then the family member used to do those activities.
Have you got the license for narcotics?
Not yet.
You've submitted?
Ma'am, application is done from the medical superintendent office, so I need to
Get back to
get back to it.
Okay. Okay.
Thank you. Yeah. Actually, documents is not up to the mark, so we send to them to send us.
Thank you, Doctor. Now going to Dr. Anisha. What are the biggest operational challenges in expanding palliative care beyond hospital settings, and how can referral system between tertiary hospitals and district level facilities be strengthened?
First and foremost, just like you mentioned before about the pain clinic, so it is very important that we have that ready. Because if we don't have that ready, when we start referring cases from the field, where will they go? So we thank for the 15 lakhs fund that we got for the district hospital, and as soon as the space is available, we are going to open that palliative care pain clinic. We have also made an application, which we are yet to get that, and that is one part of what end. And coming from the field, like Dr. Lucky has said, our field workers have done a tremendous job despite the recent training that they have got, because palliative care is something recent for even many of us. It has just recently started, but they have gone. I have seen, like in our district we have a WhatsApp group where whenever the staff, they go for a home visit, suppose if they find a difficult case, like a case of a diabetic foot which has become so bad, gangrenous and all, they used to inform us. So in that case, whoever can help will go, maybe a doctor, like that. And we used to see, like before, and they used to give a follow-up photo, after a few months, how that patient has improved, has recovered. So that is very good. It's like an example for the others also who have not yet started. And then we are also fortunate in one sense that this National Ayush Mission. I think it's only in our district or other district, I don't know. But we do have teams, the palliative care NCD team, where they go and visit the villages, a mobile unit. So these teams are trained under palliative care. They go, they teach the family members about how to care for bed sore, how to care for diabetic foot, and even how to raise a patient. I mean, for us who take care of our family members who are having stroke and all, like, we don't know how to carry a patient from bed to chair, from chair to bed. But there are steps in order to relieve the patient and the one who is carrying, because we are going to do that hundreds of times.
Yeah.
But then if we know like how to do it and somebody teaches us, so that be like it's empowering the family members without depending on us most of the time. But of course, even the rails tube changing and all, our staff, like our field workers, are doing that. So what we need is like I've already said before, is a referral system. Sometimes we have very bad cases and they have to be referred. But if like the program doesn't provide a referral transport money, it becomes difficult for us.
So actually, as you all know, we still have a lot of financial constraints. There are many things that we have to look into, and the number one thing that we've addressed now is the MLHP mobilization, because they have to travel, we send them to go to the field, but and transport in the villages, you will not get a shared vehicle.
you'll have to book the vehicle, and understanding that we have put it in PIP, but there are still so many things that we have to think about. And and since as in the morning I've talked regarding Sir Sampat's meeting that we had, he is taking NCD as a priority, and palliative care is part of NCD. We will try to reach out to the higher ups, like how they can help us, maybe by using the what do you call the vehicle used for maternal health, whether we can CMS. I forgot to see CMS. We can use that, or maybe we try to find something out. But we understand the difficulty, because right now for cancer also, like we have a pathway. Like from the field, they will go to the district hospital, so that they don't have to come all the way to Shillong for diagnosis. So if there's availability of specialists in the district hospital, they can be sent there, and biopsy can be sent there, can be done there, and we will find a way to transport the specimen to Pasture, where it will ease the patient, at least for the diagnosis part. But there's still many things that that are in the pipeline, and we will try our level best to ensure that our patients don't need to suffer more. Thank you, Alisha, for that. Ma'am, this question is for you. What are the most common needs of cancer patients requiring palliative care?
Thank you so much.
Okay, introduce you again, please.
Kabaningkong nga kerteng imotilin sa alawa banalay si Vivanta nakan Shillong Song.
Okay. Okay. So this question will be for you. Nakaliang zong ka VHC kaya kapapila ban identify yikili na marting-ting ki asaru kilabon kamle ke ting-ting nakasunong katao long bapinla ban identify yikini ki long pang ki belas ki bapang aslam kum ki stroke ki cancer ki kidney failure ki bam na ban kena sankhya kumno pila ban identify gitu bapin bentuk supoka nearest health center jumki.
Ito kung resibon mo, yung kaling tinggali. Halor ka na yung mangi ki VC member, kaay kabangi nila ban snok tilang bat ki, kadi kabangin ay minsim, kabay omday bakin ya, diyan na may bakin kanran diyan, na pidon hakanu-kanu kabenta, kam-kam kadi ka government ka jongi mo, mansupay, hakanu-kanu kabenta, pikin sa scheme, kidan scheme ki baper ban ay jinyaram. Hoan in namla ban bataya yak ina marni yung dan hakata ka level bangin ban explain na kiniki scheme te hendre ni ay minsim kiniki ko mangi ki VC member te nasuk menru hapo pasnong bakawan kanika VC member na mapa lamba kani niyo shipun ki awareness ki baki wonra na kanu ka department te mangi ki VC member ni yali ngala de ban wan shakmat lani kum ki long kami ki khana samla kantam kim de kan ong ba kin instinct kani ka de tak ka bashu pelut por mah begini snap ni bala kam long aktif ni bangi ni kam shutdown ni sim sibun kita kijingan toy ka pinyo tilang ba kata hi ni ban ai kata ka met bat mensim ting ting lang ba ka VC hiru ki don ki funds mo kita tilang ba kitu ni shong ni discuss ni ai jingyarap kat ka bangi kot kapot na kanyang jumi tahi ta syukre syuat di ngan pai pat si dalai kwa ban dep na kanyang go zongfi ke long kat tung go jing yi go zongfi ke ka awareness ka badwan ha for community Supang kenika palliative care dan kenika jing sumar ya ki nofan di prashi Islam dan ki bangla mungkin ko jintia hapo ki yin ki long kitip ne am bagaimana ka jing sumar ke bakila ban yo am ki yin jomki kumbani la yo so me ne mo na ki MLHP to ki batre boki health wellness center
Kublai sibon mau kat kum ga jing tip jong ni long ba ni kam tip nia nama pang sula pang Hebrew lah dari ba declare doktor ba dari ni symptom do cancer tinglawan mi ba sini ba tulong yu ting dua tambang iti bro bagi ni Hebrew bila ni am ban yale ja kanto ba cimpang ma teng teng di nopang tentang nak putih nak geli nak baik dari nak bahaya ba set jongki nyong kumno kiyo thia kiyo em kiyo thia gi ông cũng nói vì ba mà em làm mà tiếng năm nay mới xin nghĩ đây nó công lại mới xin cũng tự nó đây là cả ba long làm ba hạt đen cái sấy keli thì là lấy sấy áo là đơn baวันai cùngวันai chỉ ra thì xin là arkin này cái nông pang cái là được ông ba là register cái là đi saya jaga semua tinggal long bay up to date bay ini tambah kesong haga mon jom itu patient kan dan patient bangko mu tadi doktor la ong mat bam kan ni bale ong tai lo kan ong ni ro le kita ka jing dua long ni long train jam kai long tang ki sekri bare yam la pun bo re ble parang sumar bahayo ni kan e na yo ki long lai ki long tang jing pa ti ya ki bri long ka tai kan pa ti ka jing rabi ki long pang ki yo ya ka jing rab ko ba kan ba ki long pang ki bun se di Jibril dan teng kumba ya keren base pangkat tera sendrang teng lah yo ini jimpang di orang aku di galah teng aku di betul kalau sacrifice lah kan syukur kan kata
can you introduce yourself, please?
Good evening, everyone. I'm Dr. Amin Azam from Southeast Carolina.
So, according to you, what are the most common needs of cancer patients requiring palliative care? So, these cancer patients are, are under palliative care. That means in the late stages. So, what are the most common needs by these patients?
Most common needs, ma'am. First of all, they are who are not taking treatment from hospital, and so they need home-based preventive care. They mostly symptomatic care they need, and counseling. So to make them strong, to feel them healthy, we should give continue counseling, and whatever we have from our side, we have to provide our help by giving simple palliative care, symptomatic care.
Thank you. So before we wind up, I would like to request any of you, if you have any questions, please. 2 minutes. Anyone? Any questions?
Excuse me. The comment kini ki balai ki palliative care system, the ki brief kita nama kalau lifelong process gitu. Kita ki bagi melakukan care rumah, pemlak shaban semua. The comment kita ki jengarap ko, ida ki gloves, ki gauze, ki betadine. Inari bedin den na ki dispensary nearby dispensary jongi. Nama katu ko tete kalau bampore ki ki habat ko ro ki ten pagi don kamen mo. Tinginari ko mangi ki VSC member ki talk application nilani bedin den kam kita ki tiar na po dispensary.
Okay. Right now, kampadran kum kata tambah ngai kiwe ki state nai kiladan kini ki state bagi ai bagi sami kini ki families mo. We will also work on that. In fact, long what la dengim la ban ai sibon ru andre kat ke zingerap ke bangila ban ai nginya persang ban ai. But ya kata ngin sebentar bagi health facilities lada deba nila roll out dia kata. In the meantime, ingin persang kat bala di firu kum VHC nai along both sien kum cancer patients kini ki badan kam palliative care ke kebaning kong ke bangi hak ban work on dei ke mental health jong ki ke emotional health jong ki so ngi hak ban you know, long industry ki kuntu ki long marway. Tinre data jing ni tray lang jungi pan long ki ki kam scan ki kam long kim so long marway. Thank you. Any other questions?
Districts, they already have manpower.
Yeah.
So can other districts also expect manpower for efficacy, especially for like clean clinic? Like I think the district hospital nurses are already, some of them like, they're already equipped with other departments. So like, is there any?
Actually, palliative care, a few physiotherapists and nurses have been identified, but I've forgotten for which districts. So we will look into that and let you know. Because South Garo Hills have already got their license, so it will be great if you can start it. Yeah, so we'll look into that. Any other questions? So I think it's high time we wind up. Yeah, it's high time we wind up. So first of all, I'd like to thank each and every one of you. Each and every one of you have made this a fruitful day. We have had a lot of discussion, and we hope this does not remain just a discussion, but it will be an action to move forward. I have talked to the media people, and they are also, because every family is suffering from this, even if it's not near ones, but you know, our relatives are dying from cancer, our friends are dying from cancer, the people we know are dying from cancer. So I feel this is the time where we will have to move in a mission mode, and for that health department alone will not be able to do anything. So we are very thankful and very happy that you know, each and every one who was present here had agreed to really work together, from the VHCs to the media people and to the school teachers. So everyone, let us all work together to make Meghalaya reduce in the bad things that are happening to us. Because as you can see, in Meghalaya there are too many things that are happening now. HIV, drug addiction, at least now maternal health, infant health has improved a bit, and we hope to see that same improvement in these other diseases that we are fighting now. So with that, thank you each and every one of you. So thank you each and every one of you, and all of you, safe journey back home. We will meet again, we will continue meeting again, and thank you everyone.